Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Abdelrahman Al-Anani, and inshallah I will be with you in this crash course. We'll be talking about everything endocrine, everything we've taken. Of course, except for Dr. Faisal Khan's 2 lectures about the pelvis, because that's not very endocrine, is it, huh? So that's more of a reproductive objectives, so I will not go through them. So we'll be, as we said, we'll be talking about everything, hormones, first as an overview look, then pituitary gland, thyroid gland, adrenal gland, and we'll end up with the endocrine pancreas. I just want to say also thank you to Majd because he did the slides for the hormones part, the 2 lectures for Dr. Abdul Ahad. So thank you very much, and let's start. Hormones. Hormones are chemical substances that bind to receptors to exert an effect. Okay, this is a very general thing that I just said. Okay, but we can classify them based on the distance or the target that they exert their effects. So either it's an autocrine. Autocrine means that the cell produces this chemical substance and it affects itself. This is usually seen in apoptosis, when the cell kills itself, if that makes sense. Now, the second type is paracrine secretion. We'll skip the gap junctions for now. Paracrine secretion is basically that this cell is secreting a substance that affects neighboring cells. Okay? This is just a very general definition. Now, it's similar to it is the signaling across the gap junction. But the difference is here that the 2 cells are like very close to each other and they have these gap junctions that connect them. Okay? And it will release the hormone or the chemical substance and it goes to the other cell or to the target cell through these gap junctions. Now, all of these, of course, are local effects because they are very close to each other. The last one, which is this block, endocrine. Endocrine is a cell targets a distant cell through the bloodstream. It sends the chemical substance into the bloodstream and it goes to the target cell to bind the receptor and do an effect. And of course, it's distant. Now, we will also hear neurotransmitters. Neurotransmitters are local effects through synapses. So the neurons will secrete these substances and they will exert their effect usually in the synapses, like acetylcholine that we've heard a lot about. The other thing that can be released from neurons are neuroendocrine secretions, and from the name, endocrine means that they are distant. So they are released from neurons, but they go through the bloodstream, so they are distant. Last special category that we will have is cytokines. We don't know much about them here, and you don't need to know much. I just want you to know that they are peptide hormones, and one example of them is leptin, and it's secreted by adipose tissue. I hope that makes sense. Very easy concept. Now we will hear trophic hormones. Trophic hormones, we'll be talking more about them in the pituitary gland, but what I need you to know for now that they are hormones of the anterior pituitary gland, okay? And we call the pituitary gland the master gland. Why? Because it's an endocrine gland that secretes a hormone, and these hormones are trophic. They go and affect another endocrine gland, okay? So it's like the master mind that's affecting the whole body, and it targets other endocrine glands. So if the hormone is secreted by one endocrine gland and it goes to affect another endocrine gland, it's called trophic hormone. The examples we'll see later. Not needed right now. Now the hypothalamus. The hypothalamus is the master of the master gland, so it affects the pituitary gland by 2 ways. If we are talking about the anterior pituitary gland, it will be by the portal system, okay? This portal system, which are basically veins that are coming from the hypothalamus to the anterior pituitary. Why? So the hormones of the hypothalamus will be secreted into these veins because they are connected in the blood from the hypothalamus, and they will go through and towards the pituitary gland, to the anterior pituitary. So basically it transfers the hormones from the hypothalamus to the anterior pituitary gland to exert some effects. We will discuss it much more in pituitary. Now, the other thing is this connected nervous system, which is basically the neurons of the hypothalamus will continue down to the posterior pituitary gland to secrete some hormones that will be stored in there, like ADH and oxytocin, which we'll be talking about. So if it's the anterior pituitary, it will be the portal system. If it's the posterior pituitary, it will be the nervous system. And we will discuss both, inshallah. in details. Now, when we classify them, we can classify by distance, as we saw before, and we can classify them also by chemical structure. By chemical structure, we'll see the steroids. Steroids are cholesterol-derived hormones like the adrenal cortical hormones, cortisol, aldosterone, all of that, and also the sex hormones and so on. Another classification is proteins or peptides hormones, and they are most of the hormones that we'll be dealing with will be this type of hormones. They can also be coming from tyrosine. It's not only tyrosine, it's amino acid derivatives, but the one that we will be dealing with mainly will be tyrosine. Okay? And these are some examples, just to have a good idea. Now, characteristics of hormones. When we say the concentration of a hormone, it's how much hormone do we have in the blood, for example, if we talk about the concentration of hormone in the blood. Makes sense. Now, the latent period. Latent period is the time that we have since the administration of a certain hormone until it exerts its effects. So, for example, if we give someone insulin, and it takes 10 minutes before the glucose starts shifting into the cells, which is the effect of insulin. So these 10 minutes are what we call latent period of insulin. This is just an example. It might take more or less, I'm not sure. Anyways, now some hormones will circulate bound to proteins, and we will know why in a minute. But what I need you to know that if we have such a hormone, only unbounded hormones can produce an effect, which are usually 10% of the existing hormones in the body. Okay? Now, of course, as we said, the hormone will go to the target tissue, and the target tissue have these receptors that are specific on the to the hormone. So insulin receptor should be specific to insulin. It's not always like full specificity. So sometimes you will have two hormones that use the same receptor, that can use the same receptors, and we will see that later. Now, also peptide hormones are metabolized quickly after secretion. No need to know that. Now, hormones are degraded after interacting with the target because you don't want the hormone to do its effect like very strongly, or forever. So when it's done doing its job, you need to degrade it and excrete it. Some hormones, which is less than 1%, will be excreted without degradation, like in the active form of the hormone. Now, when we talk about the receptors, they can be either cell membrane receptors, or cytoplasmic receptors, or nucleus receptors. The cytoplasm and nucleus requires that these hormones can diffuse through the plasma membrane. So these should be hydrophobic and lipophilic. So they can diffuse through the lipid in the cell membrane. But the cell membrane receptors will be dealt with the proteins and peptides hormone because there is no need to be lipophilic to use them. Now, I want just to note here that not all steroids will be using cytoplasmic receptors, and in the nucleus there are some things like vitamin D that has its receptors in the nucleus, but for this block we will be only dealing with thyroid hormone that has this nuclear receptors. Their effects might be to alter the membrane permeability, affect enzymatic activity, alter gene expression, and so on. This amplification effect is important to know. This can usually be seen in cell membrane receptors. We have the hormone which will bind to the receptor. So we have one hormone binds to one receptor. This one receptor will activate one adenylyl cyclase, for example, if we're talking about the CAM pathway. One adenylyl cyclase, since it's an enzyme, let's say that each enzyme that we'll be seeing from now on will deal with 100 molecules. So it will give us 100 CAMs. CAM is not an enzyme, so it will only activate, each CAM will activate one protein kinase, so it's 100. But protein kinase is an enzyme. So each protein kinase of the 100 will deal with 100 other enzymes, so it will be 10,000. And these are also enzymes, the phosphorylated enzymes. And they will also, each one of them will deal with 100 products to produce 1 million products. So we started with how much, or how many molecules? One molecule. But we ended up with 1 million products. Can you see how big of an effect is the hormones effect? So it's important to keep in mind. Now the receptors, they can go into upregulation or downregulation. Okay, what do we mean by that? If we have high amounts of a hormone for a long time, we will have downregulation. Why? Because as we said, the effect is very strong of the hormones. So you don't want these. For example, let's say you have 10,000 insulin molecules. That's too much to handle, right? So you don't want it to be activating a lot. So you will have low amounts of receptor. Let's say you have 10,000, for example, insulin molecules, and you have only 3 receptors. No one cares about the other 9,997 molecules. Only 3 will have their effect, and the others will just be circulating. This is the importance of downregulation. Now, for the upregulation, it's the opposite. You have low amounts of insulin. Let's say you have 10 insulin molecules. So you will have high receptors to increase the chance of that one insulin molecule will bind to the receptor by accident or something, just to exert some effect. Okay? So just have in mind that downregulation happens to high amounts of hormones, and upregulation is the opposite. Now, not all hormones will have their effects done in 10 minutes or 5 minutes or whatever. It depends or changes from one hormone to the other. For example, norepinephrine and epinephrine will develop their effects in seconds to minutes. Thyroxine or growth hormone may take months. And small concentrations of hormones are needed to perform function. You don't need a lot of them, as we said, because of the amplification effect. Now, we can control hormones through 3 main mechanisms: negative feedback, positive feedback, or direct control. We'll discuss them later in the pituitary gland because it will be easier to understand then. But I just want you to know that the main mechanism that we use is negative feedback, and it prevents overactivity of hormones. And it's basically that the later product will inhibit the steps before it. So, for example, if you have a lot of the later product, the final product that you're aiming to have high amounts of it will go and inhibit the steps before it because, okay, we already have enough. The positive feedback is the opposite. It will be like an infinite cycle because you will have high amounts of the later product and it will come back to activate the steps before it. So you will have even more and even more and even more. And that only, it's very rare. You will see it, inshallah, in the pituitary gland. But then it's mostly oxytocin, which you will... it's the hormone that you will see having this positive feedback is the oxytocin. Now, the direct control is also very rare that you will see that. And it's the case when the hormone secretion is controlled by blood concentration of substances that the hormone control. So, for example, insulin and glucose. When you have high amount of glucose, insulin is secreted. Low amounts of glucose, insulin is not secreted. This is just the direct control. Now, we will have some variations for hormones activity and secretions, and it depends on a lot of factors such as seasonal changes. So some hormones are more active in the winter, some are in the summer. You will have also aging. If someone is older, they will have less activity of hormones and so on. Also sleep. Someone gets good sleep, they will have better activity and so on. Circadian rhythm we'll talk about later. Now, the transport of hormones, as we said, water-soluble hormones will be transported dissolved in the plasma. Why? Because they are water-soluble. And plasma is mostly with water, so it can dissolve. But what about thyroid and thyroid hormones, which are not water-soluble? What do we do with them then? What's the solution that we have? Well, they are bound to plasma proteins. Okay, as we said, some hormones will be bound. Do you remember? Only the free or unbound proteins can exert their effects. And hormones will be cleared from the body, and this is the equation that we use to calculate the clearance. It's not very important. I have never seen a question about it, okay? So just know it, Yeah. Okay, now for the hormonal assays. An assay is basically a technique that we use to know how much of the concentration of a hormone that we'll see in this person, for example. A good assay should be sensitive, specific, repeatable, stable, and valid. Sensitive is the sensitivity is a term that we use to describe the true positives that we have among a sample. So, if we have 100 people and 95 of them test positive to the disease, and there are 100 people that have the disease, they all have it. But then 95% of them, or 95 people out of the 100, came back positive, which is good. But 5 of them came back negative. So we have false positives, right? Now, false negatives. This shows that this test is 95% sensitive. Okay? Now, what is the specificity? It's the opposite. If we have 100 people that do not have the disease, 95 of them test negative, which is good because they are negative. But 5 people who are, they don't have the disease, they test positive. So it shows the false positive here. So this test will be 95% specific. Now, what are the assays that you use? Biological, chemical, immunological, ELISA. ELISA is the most important one, and we'll talk about the biological and immunological too. Biological assay is basically, I know that insulin shifts glucose into the cells. When I look at a person and the glucose is being pushed into the cells like a lot, I can tell that he has a lot of insulin. So you see how the effect of a hormone, you measure the effect of a certain hormone in a certain person, and then you can tell how much hormone does he have. Makes sense. Now the immunological assay is a bit different, and please focus with me here. First of all, we get an antibody or radioactive label that can bind to the same receptor that our hormone that we want to measure use. So for example, insulin. We have 100 insulin receptors, for example, and 100 insulin molecules. We will go and give this person 100 antibodies that can bind to the same receptor as insulin. What we will see, they will compete over it. The insulin and the antibody, they will compete over the receptor. You will end up having 50 receptors bound to the antibody and 50 bound to the insulin. But what if you have more insulin? So let's say you have 300 insulin. You will have more receptors bound to insulin rather than the antibody. So the antibody, once it binds, it will give us a sign, like a radioactive sign. It will give us light, let's say. The more light that you have means that more antibodies are bound, so less insulin that we have. And this is how we can measure it. Does that make sense? Now let's look at ELISA. ELISA can be used to measure any protein, and that includes hormones. It's basically enzyme linked and antibody reaction, whatever. How do we do ELISA? We'll talk about the sandwich ELISA way that we use. You will start by having one antibody that this hormone that you want to measure can bind to, if that makes sense. So we call it antibody 1. The hormone will bind. Then we will sandwich it, by another hormone. So you will have, another antibody. So you will have antibody 1 that the hormone is bound to, and antibody 2 that makes the sandwich. We will have then another antibody, which is a third antibody here, that's linked to an enzyme. This enzyme can give us a sign, a radioactive sign also. This is the only thing that I want you to know. The third antibody will bind to the second antibody. It gives us this light. The more light that we have means that we have, for each dot of light, let's say, you will have one hormone. So the more light that you have means that you have more hormones, and so on. Very easy. Now, hormone receptor kinetics. I don't want you to remember anything from here except this plot. Okay? Because it's very stupid concept, and I don't like it, so just please remember the plot. What I want you to know is the x-axis, what does it represent? And the y-axis, what does it represent? And the slope. The slope of this plot, when we talk about any hormone, we can do this plot for it. And the slope, it represents the affinity. This is the first thing that I want you to understand. If you have steeper slope, so that means higher slope, it means that we have what? Higher affinity. The y-axis will be the bound hormone over the free hormone, and the x-axis will be the bound hormones. The x-intercept here will represent the total receptor number. I know it might sound a lot, but it's 4 things and 4 meanings. This is the only thing that I want you to know. This equation, I don't think you need to memorize it. And it's actually very stupid because it's basically y equals mx plus c, the equation that we use in that you have learned for slope in algebra. Okay, this is y, the y-axis, as we said. This is our slope, which is m. This is our x-axis, okay, which is the bound hormone, and this represents c. So it's very easy, okay? I just want you to know the what each of these represent: the slope, the y-axis, the x-axis, and the x-intercept. Okay. Now, for the hormone receptor kinetics, you will have, if you give insulin a scatter plot, this is called a scatter plot, you'll see something weird. It will have two different affinities. Can you see? The first affinity is very steep, so it's what? Has higher affinity. And the other one will be less steep, so it's low affinity. Okay, so what? What does that mean? It means that insulin shows negative cooperativity. What does that mean? When you have two affinities like this, one is higher than the other, it means that the insulin is affecting other insulin molecules. How? When one insulin molecule binds to one receptor, it will affect the other receptors and tells it, okay, I already have insulin, so guys, let's not take all the insulin now. We will decrease our affinity to insulin. The second receptor gets its insulin, and then it tells, okay, let's decrease it further. Why? Because you don't want insulin to bind a lot and have a big effect. When you combine these two curves, you will have one big curve, which is this. Okay? So the only thing I want you to know from here is that insulin shows negative cooperativity. What does that mean? When one insulin binds to a receptor, the receptor will tell the other receptor, okay, guys, we already have insulin, let's calm down, okay? This is the only thing you want to know. Now, these are molecular pathways that Dr. Abdelrahman skipped. So I just put it very summarized way to refresh your memory. As you can see, the CAM pathway, you have the G protein S subunit, adenyl cyclase, CAM, protein kinase A, cell response. Cyclic GMP pathway will be G12/13. NO synthase will give us NO, which activates soluble guanylyl cyclase, give us C. Cyclic GMP, protein kinase G, and cell response. It's just to refresh your memory. I doubt he will ask about it because he said, he himself clipped and said, this is more small. IB3 pathway, you will have the GQ subunit. Phospholipase C gives us IB2, you'll have DAG, and IB3 give us calcium activates protein kinase C, and you'll have cell response. The thyroid mechanism, it passes through, the hormone will pass through the cell membrane, binds to cytoplasm nuclear receptor, and change gene expression. You'll have through these signaling pathways secondary messengers. And secondary messengers, they are what amplifies the signal in the middle. And as you can see, it could be hydrophilic, as IB3, CAM, cyclic GMP. Any secondary messenger, I put a red here, if you guys can see it. So you'll have hydrophilic, hydrophobic, and gases. Gases are self-explanatory. Hydrophilic are the most amount, so I will advise you just memorize these two. And anything else, if it's a gas, you will know it. If it's if you do not know it, it's probably hydrophilic then. This is a very important slide because Dr. Abdelrahman emphasizes on it everywhere, okay? He says you will get a lot of MCQs from this. It's basically memorization, unfortunately. But we will come back to this slide, inshallah, at the end of the crash course, once we have discussed most of these hormones, and it will be, inshallah, easy to remember. I have a very easy way to remember it, inshallah. So please just keep it in mind for now, and we'll come back to it, but you need to memorize this. Now, some questions. It's paracrine, because, neighboring cells within the same tissue. Of course, it's paracrine. Please pause if you want to solve it yourself. And it's A, because you see it has the normal is much steeper, as you can see. the normal is steeper, so it's higher affinity, so the patient has lower affinity, and it has equal number of receptors because they have the same X intercept. Can you see? Then this represents the total receptor number. So yeah. And pituitary gland. Okay, now for the start of the actual material, pituitary gland. We'll start with its anatomy. And I want you to know that pituitary gland is also known as hypophysis. And it's divided usually into two parts: anterior pituitary, posterior pituitary. Anterior pituitary is also called adenohypophysis, and it's the glandular part of the gland. Okay? Which means that it produces its own hormones. The posterior pituitary, known as neurohypophysis, it's neural part. It's made of axons and so on. And so it's called neurohypophysis. And it stores hormones that are coming from the hypothalamus. It does not produce its own hormones. Now, the whole pituitary gland is located in a depression in the sphenoid bone that we call sella turcica. Sella turcica. It's beneath the hypothalamus, and it's hanged or connected to the hypothalamus by a stalk. This stalk is called infundibulum, or pituitary stalk. So you can think of it as cherries. Can you see? This is the infundibulum, and this is the anterior pituitary, and this is the posterior pituitary. Does that make sense? If that makes it easier to interpret. Now, what is the infundibulum? We said it's a stalk that hangs the pituitary gland. It's also a continuation of axons of the hypothalamic neurons. So the neurons are coming from the hypothalamus, from two nucleus that we will discuss later, and the axons descend to make the infundibulum. It arises from an area called median eminence. It's an area of the hypothalamus itself. And this median eminence is where the hypothalamus releases its hormones to reach the pituitary gland. The infundibulum provides a pathway for the hypothalamic hormones to be stored in the posterior pituitary gland. Because as we said, it arises from median eminence. And hypothalamus releases its hormones at the median eminence. So when you look at it here, for example, this is the hypothalamus. This is the median eminence. You see, this is the infundibulum that connects the pituitary gland. The hormones will be released here, and it goes to the posterior pituitary. Does that make sense? Okay. Now, this note, we will come back to it after we see here. As we said, hypothalamus, infundibulum, okay, which hangs the pituitary gland, and we have the pituitary gland itself. This is the sella turcica, and here we have the sphenoid bone. Now, if we want to approach the pituitary gland for any surgery, will we approach it from up and cut the whole brain, or do we go from the nasal cavity? Because it's very close to the nose, to the nasal cavity. Of course, we'll go from the nasal cavity, and thus we call this approach the transsphenoidal approach. Coming from the nasal cavity, cut the sphenoid bone, and reach the pituitary gland to do any surgery that we need. Now, we can also divide the pituitary gland into another 4 divisions other than anterior and posterior. The first division, now I want you to know that pars means part, so it's a part of the pituitary gland. We'll say pars and give it a name. Pars distalis is majority of anterior pituitary. Anterior pituitary, we call it pars distalis. We have pars nervosa from nerve, so it's posterior pituitary, the neural part. Now we have pars intermediate, so it's between the two parts of the pituitary. Okay? And we have pars tubularis, which is an extension of the anterior pituitary that wraps around the infundibulum. Here you can see it. This is the anterior pituitary, right? So it's pars distalis. Here we have pars nervosa, the posterior pituitary. In between, we have the pars intermedia. And pars tubularis is an extension of the anterior pituitary that goes and wraps around the infundibulum, which is this white part, or white stalk. Okay? It wraps around it. Now, the relations of the pituitary gland. It's neighbored by some important structures that can be compressed if there is a tumor. The first one is optic chiasm. We'll discuss it in a minute, but just please keep it in mind. Optic chiasm, internal carotid artery, and cavernous sinus. Cavernous sinus is a venous sinus, so it's basically an artery and vein that can be compressed. And we have here the optic nerve and some cranial nerves that are important for vision and eye movement. As you can see, this is the pituitary gland. Here we have the carotid artery, internal carotid. Here we have cavernous sinus. We have the optic nerves. So these guys can be compressed because they are very close if the pituitary gland will be enlarged. Now, bitemporal hemianopia. This is very easy concept and it's very important one. So please focus on me. These are the eyes. Here we have our nose, and here we have the pituitary gland. Does that make sense? Okay. Now look with me. If we have some light that's coming from the side, either right or left, it will come this way and it will hit the medial fibers of the optic nerve. So we have medial fibers and lateral fibers of the optic nerve. The medial fibers, which are close to the nose, will be hit by lateral light. Okay, this light will come and hit the medial fibers. Does that make sense? Okay. What if some light is coming from the nose side? It will come and it will hit the lateral fibers. So they do this crisscross. Does that make sense? Okay. Now look how these fibers will travel. The medial fibers will go this way and it does this crisscross in front of the pituitary gland, which we call the optic chiasm, this X. The lateral fibers will go away from the pituitary, so we don't care about them. Now, let's interpret what could happen if the pituitary enlarges. If it enlarges, it can compress this X that we have here, the optic chiasm. And if it compresses the optic chiasm, which fibers did it press or compress? The medial fibers, which get light from which side? The lateral side. The lateral side we also call temporal side. So this person will show up, they can see the light that's coming towards their nose. But if we are asking them about the right and the left, they can't see well. And this is what we call bitemporal hemianopia. Okay? Easy. Now, this is the pituitary gland, the optic chiasm. This is just an MRI that I put here so you can interpret what's happening. Of course, beneath the pituitary gland, we have the sphenoidal air sinus because it's close to the pituitary gland is close to the sphenoid one. So the pituitary gland gets a very unique blood supply. Why? It's specifically the anterior pituitary. Let's see what happens. We have the internal carotid artery that's next to the pituitary, right? So it makes sense that it will give us the branch that will supply it, superior hypophyseal artery. Superior hypophyseal artery comes near the pituitary gland, supplies the median eminence and the infundibulum, and it gives us the primary capillary plexus. Okay, makes sense. Now, after an artery gives a capillary plexus, what will you expect? You will expect to have venules. After the venules, veins, and then bigger veins, and then superior cava and inferior cava. This doesn't happen here. We have long portal veins. And these long portal veins will give us secondary capillary plexus, so they will branch after. Why? Do you remember the portal vein in the GIT? Didn't it branch after it goes to the liver to dump the blood into the liver? Yes, it also here branches. And it supplies the anterior pituitary. So the anterior pituitary does not get a direct arterial supply. But why? Why do we do all of that? As you can see, the superior hypophyseal gives primary plexus. Primary plexus goes through the long portal veins to supply the pituitary by the secondary plexus. But why? I'll tell you. Didn't the superior hypophyseal give us this capillary plexus near the median eminence because it supplies it? The hypothalamus releases its hormones where? In the median eminence. So the hormones will go through these plexus and then to the long portal veins, then to the secondary plexus and reach the pituitary gland, the anterior pituitary. Why? To exert its effect on the pituitary directly. You don't want the hypothalamic hormones to go circulate in the whole body, then reach the pituitary. No, it makes sense that you want it to have a direct connection. Okay, easy. Now, we have also another thing that's special here, which is that the secondary plexus have a feedback lobe with the hypothalamus. How? By long portal veins. So you have this secondary plexus, and then you have, sorry, not long portal veins, short portal veins. I'm sorry. The first one was long portal veins. Now we have short portal veins. They basically take the hormones of the anterior pituitary back to the hypothalamus. Why? Because you want to have a feedback lobe. If you have too much anterior pituitary hormones, you want the hypothalamus to stop, to tell the pituitary to stop. So you want this negative feedback. And vice versa. If it's slow, you want more hormones, and so on. What about the posterior pituitary? Very simple, alhamdulillah. It gets its supply by the inferior hypophyseal artery, directly. Now, hypopituitarism. It's a deficient pituitary gland, basically. It can be due to many reasons. Either an unsecreting tumor in the pituitary that compresses other secreting parts. So it's a tumor in the pituitary that it does not secrete by itself, but rather it goes and compresses other secreting parts. So you will have low pituitary hormones. Sheehan syndrome, very important syndrome that it's very likely to have a question about this in the final, which is an infarct of the anterior pituitary following postpartum bleeding. Why? Why is it the anterior pituitary that gets the damage? Why not the posterior, for example? Do you remember the anterior pituitary did not have a direct arterial supply? It gets its supply through these long portal veins, and they are getting deoxygenated blood. So it's getting already low oxygen. So once the oxygen goes even lower after a woman gives birth and it's postpartum bleeding, it can have this Sheehan syndrome, which is dying of the cells in the anterior pituitary. It's similar to zone 3 in GIT, if you remember, in the liver. Now, you might also have empty cella syndrome. It's idiopathic atrophy of pituitary, or pituitary apoplexy, which is sudden hemorrhage of pituitary that compresses the gland and causes hypopituitarism. Now, also there is anterior pituitary tumors, and they are the most common cause of anterior pituitary disorders. Most patients that will present with a problem in the pituitary gland, it will be mostly tumors or adenoma. They will have headache and visual disturbance due to the expansion on the optic nerve. They may hypersecrete if it's a secretory tumor, or hyposecrete if it's non-secretory tumor, as we just discussed. And it's usually approached through transphenol surgery, as we also discussed. Now, for the embryology of the pituitary gland, it's two different parts, so it will have two different origins. Okay, the anterior pituitary will come from the oral osteomodium ectoderm. Okay, basically the ectoderm that's around the mouth. Okay, this diverticulum of the ectoderm will be called Rathke's pouch. Okay, it has three walls. This Rathke's pouch. The anterior wall will give us pars distalis. Posterior wall give us pars intermedia. Makes sense. The lateral wall will come up and wrap around the infundibulum to give us the pars tuberalis. Now the posterior pituitary will come from the neuroectoderm. So it's also ectoderm, but it's coming from neuroectoderm. Neural tube, I mean. Neural tube will give us prosencephalon, which is not important. What I want you to remember, the diencephalon. This diencephalon is a division of the neural tube, and it will give us a diverticulum that we call infundibulum. Not the infundibulum that hangs the pituitary. No, this is an embryological infundibulum that will give rise to the neurohypophyses, and it gives us median eminence, the stalk, which is the actual infundibulum that we talk about usually, and the posterior pituitary gland. So the posterior pituitary is more like a dilatation of the infundibulum that's coming from up. So the infundibulum is coming down, and then it gives us this cherry-like structure, which is the posterior pituitary. This is a functional division. When we say the neurohypophysis is also contains median eminence and stalk and posterior pituitary, because the median eminence is part of the hypothalamus. Don't mix it up. Okay, but it comes from the same origin, which is the infundibulum. Now, this begins at the 4th week, and by the 8th week, Rathke's pouch is going to move upwards, okay? Because look, as you can see here, this is the oral cavity, and we have here the nasopharynx or whatever, no one cares. What I want you to keep in mind is that the nasal cavity and the cranial cavity will be open to each other. Because the sphenoid bone is not yet developed well. Okay, so it's open. Rathke's pouch will go upwards. The diverticulum, which is the infundibulum that's coming from the diencephalon, will come downwards. And they will meet each other to form the anterior and posterior pituitary gland. Now, once they form, the sphenoid bone will close to cut off the connection between the nasopharynx or the nasal cavity with the cranial cavity, if that makes sense. Now, I also want you to know that this diverticulum that's coming, and it's giving us the posterior pituitary gland, I mean the infundibulum here, it sends signals. Once it starts going down in the 4th week, it sends signals towards the oral ectoderm. These signals, which are some genes you don't need to know, they will pull Rathke's pouch towards them. Okay? Once the oral ectoderm is pulled and it gives Rathke's pouch also will start pulling on the infundibulum. So at first it's just the infundibulum that's giving us these signals to pull the Rathke's pouch towards it. But then once it's formed, it will also pull the infundibulum towards it, so they both pull on each other, as you can see. Now, this is a newborn pituitary, which is which is basically this tiny thing, and as you can see, it's very shiny on the MRI. Now, what if the sphenoid bone does not close? The pituitary gland has formed, but then it did not close the sphenoid bone. We could have transsphenoidal encephalocele, which is basically that the pituitary gland will drop down in a sac. This sac is the meninges, by the way, that covers the whole brain. So the meninges, it can contain other things other than the pituitary, which is the hypothalamus, third ventricle, or optic chiasm, or whatever. They can be also there. Now, how will the newborn present? They usually present with difficulty eating and nasal obstruction. Why? Now you have this pituitary gland that's in the nasal cavity. It will obstruct this, right? So they will not be able to breathe well. So they will breathe from their mouth. When their mother tries to breastfeed them, what will happen now? The mother will close the baby's mouth. So they will try to breathe through their nose, but then it's obstructed. So they will feel suffocated. The mother will come to you with the baby and says the baby does not eat. But this is not the actual problem. The problem is transsphenoidal encephalocele. Hypoplastic pituitary is small pituitary gland. They can usually survive on hormonal replacement because it will not give us enough hormones, but they can take hormone replacement therapy. But if they do not have it at all, aplasia, they cannot live. They usually present with dwarfism. Why? Because they have deficiency of growth hormone. The pituitary gives that growth hormone. We don't have pituitary, or it's very small, so they will be having dwarfism. Now, ectopic pituitary will be just a bright spot. It means that the pituitary is not in the sella torcica for some reason, okay? It's usually, they usually also have dwarfism, and they have dysfunction of the pituitary or the anterior pituitary, and it's related to the absent infundibulum. Because when it's not in its place, it will not have the infundibulum. If it does not have the infundibulum, it will not have the unique arterial supply that we've talked about. So the hypothalamus will have no control over it. So it might be dysfunction. Have some dysfunction. It's associated with midline CNS abnormalities. These are some examples. You do not need to remember them, okay? It's just midline abnormalities will be associated with ectopic pituitary. Now, craniopharyngioma. This is a bit tricky. Why? Craniopharyngiomas are similar to anterior pituitary tumors, okay? Because they arise from epithelial cells of the central nervous system, okay? That are close to the pituitary gland. So they will compress the same structures that the pituitary compress. As you can see, they can cause white temporal hemianopia and so on. And it looks even like a pituitary tumor in the MRI. But how to differentiate between them? This can be done by looking at the pituitary hormones levels. If it's affected, this means that it's from the pituitary, the problem. If it's not affected, this means someone comes with bitemporal hemianopia or heminopia, and their levels are like very normal of pituitary hormone. This means that it's a craniopharyngioma. Now, you might have two types. Either it's ACB, which is embryonic. This means this comes from an embryonic remnants of Rathke's pouch that will give us this tumor. Or it can be metaplastic, which means that it's coming from the pars tuberalis, but the epithelium changes, which is why we call it metaplastic, and it gives us this tumor. Not important, but just know how to differentiate between both. Okay, now for the histology of pituitary gland, it's very simple. As you can see, this is the pituitary gland. This is the optic chiasm. It's anterior and a bit up. So you can see here, it's going to be above, a little bit above the pituitary gland. We have also the hypothalamus here. The infundibulum, I think blue would be more suitable here. Yeah, the hypothalamus, the infundibulum. And you have this space above the hypothalamus, which is called the third ventricle. Okay, you do not need to know much about it for now. Now, I want to also to know here that the posterior pituitary appears lighter in color. Okay, it's always going to be lighter. Why? Because here it's a glandular structure, and these are unmyelinated axons of the posterior pituitary. They always appear lighter in histology. As you can see, just by looking, you can tell that this is going to be the posterior and this is anterior because it's lighter in color. And of course, this is the pars nervosa, pars distalis, pars tubularis, and tuberalis, and pars intermedia in the middle. Very easy. Now, when you stain them by a special stain, they will give you 3 types of cells. The anterior pituitary, I mean. Okay, only the anterior pituitary. It will have chromophobes. Let's go back to it. Okay, chromophobes. They stain pale, okay? And they form the majority of the cells. But they do not have a specific function. We don't know what they do, okay? So let's set them aside and look at the other 2. The acidophils, which are pink staining, they are like eosinophils in H&E staining, if that makes sense. And they are 30 to 40%, so they are second most. Last thing, we have basophils, which will stain blue to purple, stain like the basophils we have in H&E stains also, which will give us 10 to 20% of the cells that are there. Now let's discuss the acidophils and basophils in details. The acidophils will be PAS negative. I don't want you to know what PAS is, just know they are PAS negative. This is the staining, the type of staining that will have to them. They are PAS negative. Acidophils, PAS negative. They will be 2 main cells or type of cells. The first type will be the most numerous in the anterior pituitary, when we are, of course, after excluding the chromophobes. It will be somatotropes. And soma means body, so it will secrete the growth hormone, and it will be 50%, so it's most. I just want you to know that it's most. Don't memorize the percentage. So somatotropes will give us growth hormones. Soma, body, so it's growth. It gives us growth, okay? The other one will be lactotropes, which will go from the name lacto, prolactin. Very easy. Basophils will be PAS positive. Of course, since they are different, if this is negative, this will be positive. It's obvious. And they will be 3 types of cell. Corticotropes, cortex. So it's given us ACTH, which will affect the cortex of the adrenal gland. We'll discuss later. Gonadotropes, gonads. So they give us LH and FSH, which will affect what? The gonads. And the thyrotropes, which are the least in amount. I want you to know the most and least, okay? The least in amount, they are thyrotrope, which will give us TSH to affect the thyroid. Now, the posterior pituitary, as we said, it's unmyelinated axons mostly. And I want you to keep in mind that you will see, most likely you will see 3 things there. You will see nuclei. These nuclei are not neurons. Why? Because the neurons are in the hypothalamus, if you remember. These are just axons. So what are the nuclei? What are these? They are called pituicytes. Pituicytes are glial cells, so they help the neurons. And they are found in pituitary gland, so they are pituicytes. Very easy. Unmyelinated axons, which is most of the the posterior pituitary. And lastly, we'll have dilated, this is the most important one, axon terminals filled with neurosecretory granules. We call them hearing bodies. Basically, they are axon terminals that have these hormones of the hypothalamus that store these. As you can see, you will see some nuclei here. Let's put blue. Some nuclei here and here and here. So they are pituicytes. You will see all of this whitish thing. You don't have here collagen or anything. So these will be unmyelinated axons. And these dilated things, and here in this special staining, they will be black hearing bodies. Okay? That's it. Okay, now for the physiology, we'll start by talking about the anterior pituitary first. And I want you to know that the anterior pituitary, as we said, it has tropic hormones and non-tropic hormones. When we say a tropic hormone, it means that it affects another endocrine gland. Okay? So, we have 4 examples of these tropic hormones, ACTH, FSH, and LH, TSH. And as you can see, the ACTH affects the adrenal gland cortex. So adrenal gland is another endocrine gland. FSH and LH affect the gonads, and TSH affect the thyroid gland, which is also an endocrine gland. Now for the non-tropic hormones, only two that we have in the anterior pituitary, which are the growth hormone and prolactin. Growth hormone mainly affects the liver and muscles and bones and so on to affect the growth, So it does not affect an endocrine gland. Prolactin affects mammary glands, which are exocrine, not endocrine, okay? So, yeah. Now, for the hypothalamus, as we said, the pituitary gland is the master gland. It affects other endocrine glands. But the hypothalamus is the master of the pituitary gland. So it affects the pituitary. Now, it releases hormones that affect each hormone of the pituitary gland that we have just said in a minute. And CRH stimulates ACTH. Okay? CRH is short for corticotropin releasing hormone. So from the name. Here we have gonadotropin releasing hormone, which stimulates FSH and LH secretion, which makes sense also from the name. Thyrotropin releasing hormone, which also from the name stimulates TSH. And it has a side effect, which is stimulating prolactin secretion. And we will see in a minute why is that important to know. Now we have also growth hormone releasing hormone and growth hormone inhibiting hormone. I want you to know that the inhibiting hormone has another name, which is somatostatin. Okay? Similar to the one that we studied in GIT. And of course, somatostatin always inhibits everything, so it will inhibit the growth hormone. Now, dopamine, which inhibits prolactin secretion, and this is a very important point that we will discuss later, inshallah. Now, this is a pattern that you will see when we are talking about any one of these hormone or any gland, which is the hypothalamus pituitary axis. This is the pattern where the hypothalamus will secrete the hormone. For example, let's say it's CRH, and it affects the anterior pituitary, right? So the anterior pituitary will release a tropic hormone. For example, if we are talking about CRH, it will release ACTH, right? Now this ACTH will go to another endocrine gland, okay, which is the cortex of the adrenal gland, and it will give us the final hormone, which let's say it's cortisol. Cortisol will go and affect target tissue. This series of events from the glandular structure that releases a hormone goes and affect another glandular structure and so on and so forth, we call an axis. Okay? Now we will also see that we have always a feedback, either it's negative or positive. Negative feedback is when the final hormone inhibits earlier steps. The final and in positive feedback is the final hormone stimulates earlier steps, which is very rare, and we will see a few situations, but it's very rare. Now we will have the circadian rhythm. Circadian rhythm, what I want you to know about that is it's basically an internal biological clock. Okay, it's regulated by suprachiasmatic nucleus, which is in the anterior hypothalamus, and basically circadian rhythm is responsible for hormones secretion patterns from the pituitary gland. What I mean is, some hormones will peak, the secretion of certain hormone will peak at the morning, while others will peak at the night, and for many reasons, okay? But I want you to know that ACTH will peak in the morning and decrease at night, while growth hormone will peak during deep sleep, and TSH will peak overnight and decrease late afternoon. Okay? Especially the ACTH and growth hormone, they are the most important ones. Now, if someone's sleep is not maintained well, or there's disruption in the cycle, it will lead to mood disorders and so on, because the hormones will not be released according to the plan that the body wants. Okay. Now, how does the body know that it's night or in the morning? Is it 7 a.m. or 8 p.m.? It does not, but it depends on the light. So this is basically your eyes seal the light. The light goes into the it's a part of the brain that processes it. What I want you to know is that when there is dark and it's time for sleep, a gland called pineal gland, okay, will release melatonin. Melatonin is the hormone responsible for sleep. So this is how your body knows that, okay, now we are at night, I should sleep. Okay? Now the anterior pituitary hormones, they share among them, they have some traits that they share. First of all, they are all peptide hormones, and they are all water soluble because they are peptide, so they can't cross cell membranes, so they use membrane receptors. Okay, they are stored in granules and released by exocytosis, and they have relatively short half-lives. Now, because these are peptide hormones, they must be given by injection, not orally, because if you take them orally, they will be digested in the GI tract. Let's start with the growth hormone. Growth hormone is secreted by somatotropes, as we said before, in a pulsatile pattern. This pulsatile pattern you will see for all anterior pituitary hormones, okay? Now, it's stimulated by, as we said, growth hormone releasing hormone. We have here also deep sleep because of the circadian rhythm that we just discussed. We have ghrelin, which is the hunger hormone, okay? Stimulates it. Also exercise, hypoglycemia, because it has an effect of increasing blood sugar. We will discuss it in a minute. Stress and fasting also. Now, it's inhibited by the opposite. So here, growth hormone inhibiting hormone, which is somatostatin. IGF-1, which is a negative feedback, because we will see in a minute that IGF is a product of growth hormone, so it will come back and inhibit it, okay? We'll discuss it in a minute. We'll have free fatty acids, obesity, hyperglycemia, in opposition to hypoglycemia, and aging, okay? Now, the effects of growth hormone, I want you to think of it like a bodybuilder, okay? When you look at a bodybuilder, what do you see? A huge person that has low fat but high protein, high muscles, right? So this is basically what you will see. First of all, it has sodium retention effect, which is not very important. It decreases insulin sensitivity because it counters insulin, as we will see in a minute. It does lipolysis, so it breaks down fat, as we said, low fat. And it it stimulates protein synthesis because, like a bodybuilder, high muscle. And this person will be huge, so it's epiphyseal growth, so bones will start growing under the effect of growth hormone. And also the muscle because of the protein synthesis. Now, this is the last thing, and it's one of the most important parts that you should keep in mind, is IGF production from the liver. Okay? IGF on its own will go and produce other effects. The last thing, two effects, which are protein synthesis and epiphyseal growth, are shared with growth hormone, and they make sense because it's a product of growth hormone, so it will do the same job, right? But then, when you look at the first two, you'll see that insulin-like activity and anti-lipolytic activity, lipolytic activity. But that doesn't make sense because then it counters the growth hormone, right? Well, it's because we look at it in a wrong manner, okay? IGF and growth hormone are rarely high together at the same time, okay? They do different jobs, basically. And why are they rarely high at the same time? Because when you have high IGF, it will inhibit growth hormone. So you will have high IGF with no growth hormone, so IGF will do its job. When you have high growth hormone, that means that you still have low IGF and the growth hormone will be the one dominant. Once it starts stimulating IGF release, it will increase and now IGF will do the job and growth hormone will be inhibited. So they do not do the same job exactly. And IGF is short for insulin-like growth factor. So of course it will have insulin-like activity, There's a way to remember. Now, growth hormone has dual metabolic role. Its main role is when someone is fasting, okay? Because it counters insulin, as we say. It will help at fat mobilization and lipolysis because you want to use the stored fat that you have. It reduces muscle wasting, okay? Because when you are fasting, glucagon will try to break down your muscles, but then growth hormone will try to stop it because you don't want to use the muscles. We have fat, we can use that instead of wasting our muscles because our muscle has function, and it spares glucose, okay? Now, when you are fed, it will be low, but it's still present. Why? Why would it be present when you're fed? Because, as we said, it has an effect of protein synthesis, which is exactly what you want to do when you're after you have eaten. So it will take the amino acids and make protein, and it will help with the growth. This is the axis that we have mentioned, and as you can see, IGF and free fatty acids and somatostatin, all of them will go and inhibit the release of growth hormone, while growth hormone releasing hormone and ghrelin will stimulate it. We discussed these guys. Now, the diseases that are related to growth hormone are very important. First of all, gigantism, which is excess growth hormone secretion before epiphyseal closure. What I want you to know is that bones have these epiphyseal plates. When someone is young, okay, these epiphyseal plates are not closed yet, so the bones can still grow. Gigantism is when someone has this excess growth hormone before the epiphyseal closure. So what will happen? Their bones will grow, so they will have excessive height. They will be very, very tall, okay? And they will have enlarged hands and organs. But what if this excess secretion happens, for example, due to a tumor that presented after the epiphyseal closure? So the bones cannot grow anymore. So what will we have? Acromegaly, okay? Their height will be normal because epiphyseal plates are closed, okay? But the different thing here, or the effect of growth hormone, will be enlargements of hands, feet, nose, jaw. These are called acro. So this is acromegaly. And this is the most important part and the key word that you will see a lot. Once you see it, no, it's acromegaly 99% of the time. Coarse facial features, okay? Dr. Yaqeen loves to ask about this. Now we have dwarfism, which is basically deficient growth hormone before epiphyseal closure, mostly. And it will be, a person will present with short stature, increased body fat, because growth hormone broke down fat. Now you don't have it, it will be increased, and decreased muscle mass. So it's the opposite of the effect of growth hormone. Laron dwarfism is a variant of dwarfism, where growth hormone secretion is normal, but the receptors of growth hormone on the liver are impaired. So the lab findings will be low IGF, because you are not producing IGF, the receptors are not there. But you will have high growth hormone because you are trying to compensate. If that makes sense. The pituitary is releasing growth hormone, but IGF is not inhibiting because it's slow. So it will continue secreting. Okay, now for ACTH. First of all, it's secreted as POMC, as we said, from corticotrophs. Now, what's POMC? It's a precursor, okay? This precursor will be cleaved to give us 4 products. First of all, ACTH, our main thing. And it stimulates cortisol synthesis and secretion and androgens too. Aldosterone, but to a lesser extent, not very important for aldosterone. We'll discuss it in details in adrenal gland. Now, another product that will come from this cleavage will be melanocyte stimulating hormone, MSH. And from the name, it's responsible for pigmentation. Endorphins, which are very strong, potent opioids. They are not very important to know now, but they are responsible. For example, if someone breaks their hand, they will not feel the pain right away. Okay, if someone breaks a bone or something, they do not feel the pain right away, actually, because these endorphins will cancel any pain for a period of time before they actually start feeling anything. Lipoproteins, which are responsible for fat metabolism. But the most important thing is the first two. Now, as you can see, each ACTH that we release, it will come with one MSH, right? Because they are coming from the same thing, from the same precursor. So when you have high ACTH, you will have high MSH, and MSH is responsible for pigmentation. So any patient that will present with high ACTH will present with hyperpigmentation. Now, it's stimulated by, as we said, CRH, stress, very important one, hypoglycemia, because cortisol counteracts insulin. Circadian rhythm, as we said, it's very potent in the morning. You will have more of ACTH. In the night, it's less. It's inhibited by cortisol, by negative feedback, and it binds on MC2 receptors, on zona fasciculata, which are the receptors for ACTH receptor. Now, I want you to know that how does the hypothalamus tell, okay, I have high cortisol now. How does it know it's high? Well, the hypothalamus has what we call a set point, where it has a lower end and a higher end. And the value of cortisol needs to be maintained within this range, right? Okay. Now, if the cortisol goes above, it will come back and inhibit the hypothalamus and the anterior pituitary. Is that okay? Okay. Now, that's only if it's acute, this high cortisol. If this high cortisol is chronic, it's there for a long time, the hypothalamus can reset its values. So, for example, if the lower value was 10 and the upper was 20, and now we have always high cortisol, the hypothalamus can say, okay, then the lower end will be 20 and the upper end will be 30, okay? So it can reset the axis, set point. So this explains why in PTSD and chronic depression, which is basically chronic stress, okay, are linked to excess cortisol. Of course, yeah. Now, Cushing's syndrome. It's basically when someone has excessive cortisol production. Either it's because of ACTH, where they will have high ACTH and high cortisol, of course. And that will be, for example, if someone has a pituitary adenoma. That's what we call Cushing disease. Cushing also could be ectopic ACTH, coming from ectopic ACTH, okay, which is non-pituitary tumors. Because for some reason, small cell carcinoma, which is cancer of the lung, loves to secrete ACTH. It can be ACTH independent, so the problem is not coming from the ACTH, but rather from the cortisol itself. If that's if it's coming from the adrenal adenoma or cancer, and it's secreting from the adrenal gland itself high cortisol, or someone is taking exogenous glucocorticoids and getting it from outside. They will present with moon face, buffalo hump, central obesity, because cortisol raises blood sugar and stores fat and so on. So they will present with this stuff, and we'll discuss it more in the adrenal gland part. Now, Addison's disease is the opposite. It's primary adrenal insufficiency. You have low cortisol, okay, and high ACTH, because ACTH will try to compensate. They will present with fatigue, weakness, hypotension, because cortisol and also primary adrenal insufficiency affects aldosterone too. So you will have hypotension, and they will present with hyperpigmentation, as we said, because when you have high ACTH, they will have hyperpigmentation. And this is a summary for both, as you can see. I don't know if you get the reference, but whatever. You will have high cortisol in Cushing and low cortisol in Addison. Okay? Okay. Now, TSH. Secreted from thyroid in a pulsatile pattern, which peaks at night, as we said before. It's stimulated by TRH from the hypothalamus and cold exposure to less extent. Inhibited by T3, mainly, and T4, which are the hormones of the thyroid gland, so negative feedback. Also, somatostatin, glucocorticoids, and dopamine affected for some reason, but it's not very important. Now, the effects. T3 and T4 hormones will be secreted from the thyroid gland when you have TSH, as we said. And it has a trophic effect, which is enlargement of the thyroid gland. And we'll discuss more about it in the thyroid chapter. Now, I wanted to know about the structure of TSH, that it's a glycoprotein made of two subunits. Alpha subunit is shared between TSH, FSH, LH, and the human HCG, which is the hormone in the placenta, if you remember, that we've taken an FND. Human... Okay, I forgot the name. Whatever. But then it has also a beta subunit, which determines the specificity of each of these hormones. This is what makes them different from each other. Now, because they share one subunit, sometimes a pregnant woman might present with high thyroid activity, but the woman's TSH is normal. Yes, but she has now high HCG because she's pregnant, she has a baby in the placenta and so on. So it can stimulate the thyroid gland sometimes because they share a subunit. Now, hyper versus hypothyroidism. I will not dig deep into it because we'll discuss it in a very detailed manner in its chapter. Now, the primary hyperthyroidism, you will have, of course, high T3 and T4 when you have hyperthyroidism, and low TSH because of negative feedback. The opposite will happen in hypothyroidism. You'll have low of them, high TSH because it's trying to compensate. Easy. Now, why we say primary? When we discuss any disease, a primary defect is coming from the gland itself that's releasing the hormone. So primary hyperthyroidism means the problem is from the thyroid. Primary hypothyroidism, also the problem is from thyroid. But sometimes we will say secondary hyperthyroidism. What does that mean? It means that the problem is not the thyroid gland, but rather from the anterior pituitary that's affecting the thyroid gland. Does that make sense? This is what we call secondary. And we will see later also. What will happen to the lab findings then? If it's a secondary hyperthyroidism, for example. So the main problem is the anterior pituitary. Hyper, so it's secreting more. So you will have both high TSH and high T3 and T4. Just keep it in the back of your mind, if that makes sense. Now, TSH is more sensitive than T3 and T4. So when you are trying to know if the person has a problem with its thyroid, with their thyroid gland, the first thing that will change on the lab findings will be the TSH levels. So you will order it first. But you determine whether it was hypo or hyperthyroidism by T3 and T4. Now, FSH and LH. They are released from gonadotropes in a pulsatile pattern. Gonadotrope releasing hormone will stimulate the release, and 6 hormones will inhibit them because of negative feedback. There's a tiny exception that we'll discuss in a minute. I mean about the negative feedback. Now, to stimulate them, this gonadotrope releasing hormone should be released in a pulsatile pattern, just like the hormones themselves. Continuous stimulation will lead to down regulation that we have discussed before, and it will decrease both. We had a question in TBL, I think, about this. Now, gonadotrope releasing hormone agonists can be used to suppress gonadotropes in prostate cancer and endometriosis due to this fact that we just said. Because continuous supplement of this hormone will actually decrease FSH and LH. So if someone has prostate cancer or endometriosis or any problem with the FSH and LH and you want to inhibit it, you can give continuous gonadotrope releasing hormone. Now, the menstrual cycle and their effect on it. I want you to know that the menstrual cycle is divided into 3 phases. We start with a follicle, which is like a ball that has the ovum inside of it, but it's immature, okay? The first, now after that, the follicle will rupture and give us the ovum. And then the ovum, the follicle, like the bag that the ovum was inside, will turn into what we call corpus luteum. Okay, this corpus luteum will secrete some hormones. Now, I want you to know the effect of each of the FSH and LH on these stages or phases of menstrual cycle. The first stage, which is the follicular phase, FSH is basically short for follicle stimulating hormone. So it will stimulate this follicle to grow. Okay, so the main hormone that's dominant in this first phase will be FSH. Okay. Now, once the follicle is big enough to rupture and give us the ovum, what we will have LH surge. This second phase that we call ovulation. What does that mean? LH will come and try to put pressure on the follicle as much as it can until it ruptures and give us the ovum. So this is called ovulation, this powerful LH surge. Now, the third stage, which is the corpus luteum, after the follicle turns into a corpus luteum, we call it luteal phase from luteum, and it's basically the phase where you have this hormone secreting corpus luteum. Look at the feedback. This is the main point. The follicle is growing by FSH at the first phase, which is from days 1 to 40. Negative feedback by moderate estrogen inhibits. So we have what? Moderate feedback, which is negative feedback, by moderate estrogen. And it's very self-explanatory. Now, the ovulation phase is the different one. Because the follicle needs to rupture. We don't want to inhibit. We want it to rupture. So what we will have, positive feedback by estrogen stimulates LH surge. Okay? And it's the only positive feedback seen in this axis, in this ovulation phase. Because LH will come and it will pressure the follicle to rupture. So you will have high estrogen, but it does not matter. It will have positive feedback. The high estrogen will go, and instead of inhibiting, it will produce more LH. Now, the luteal phase, you have corpus luteum, which forms and releases progesterone and also some estrogen. So it will have also negative feedback because خلاص, we're done with the ovulation. So the only exception here to everything that we have taken so far will be the ovulation phase, where you will have positive feedback. And this is a summary. Okay, you'll have negative feedback happening over most of the cycle, and in day 14, the ovulation phase, you will have what? Positive feedback. Now, FSH and LH in males. The effect is, of course, different. FSH will affect what we call Sertoli cells, S, and it does spermatogenesis. Okay. Sertoli cells also release a substance that we call inhibin. From the name, inhibin inhibits. So it inhibits FSH. LH will affect Leydig cells, so L with L, and they produce testosterone. Okay. Testosterone will inhibit LH by negative feedback, basically. Primary hypogonadism, خلاص, you can interpret yourself at this point. It's very easy, يعني. Since it's primary, it will be testicular failure from the testicle itself, and you have low testosterone and high LH, FSH trying to compensate. Secondary hypogonadism, you will have pituitary failure from the pituitary, the problem, and you have low testosterone and low LH and FSH. Now, prolactin, secreted by lactotropes, stimulated, as we said before, by TRH. Why is that important? Because that explains high prolactin hypothyroidism. Didn't we say that we'll have high TSH and high TRH and hypothyroidism because we're trying to compensate? Yeah. So these patients might present with lactating from... they might present with lactating while they are not pregnant or they are have not given birth. Okay? Because they will have high prolactin. Estrogen 2, stress, infant suckling, and this is very important. When the baby is being breastfed, the suckling that the baby makes on the gland itself will stimulate the release of prolactin to affect it. Now you'll have it's inhibited by dopamine, as we said, and this is very important because this is the only hormone that's under continuous suppression of the hypothalamus. Because for example, when you look at a woman, she's not always lactating. It's only when she gets pregnant or that she had given birth, right? Why is that not the case usually? Because it's usually suppressed by dopamine. So if we cut the connection between pituitary and hypothalamus, like stroke damage, for example, you cut the infundibulum, all hormones will decrease because they are usually stimulated by the hypothalamus. The stimulation is gone. Except prolactin, because it's usually inhibited. Now the inhibition is gone, so it will be more than usual. Now prolactin effects, it will be milk production and ejection, inhibiting gonadotropin releasing hormone, so it can cause amenorrhea, which is no menstrual cycle, and other stuff like maternal behavior, nothing important here. Hyperprolactinemia in women will present with galactorrhea, which is a lot of milk production, amenorrhea, because they inhibit gonadotropin releasing hormone, and infertility. Hyperprolactinemia in men, decreased libido, because of course, inhibiting gonadotropin releasing hormone, erectile dysfunction, same thing, gynecomastia, because the mammary gland will enlarge. Now, antipsychotic drugs inhibit dopamine, so they will present with hyperprolactinemia. Anterior pituitary tumors are mainly prolactin-secreting tumors unless proven otherwise. So the main tumor that you will have in the pituitary will be prolactin-secreting tumor unless proven otherwise. Keep this in the back of your mind. Now, the posterior pituitary. The hypothalamus synthesizes two hormones in their precursor form, ADH and oxytocin. ADH will be majorly produced from the supraoptic nucleus, while oxytocin will be from the paraventricular nucleus. Okay, these are the nucleus of the hypothalamus that release these two. And it's majority. I'm not saying that all of it will be from this and all of this will be from there. Now, they get processed during axon transport. So they are released from the nucleus and they are transported to the posterior pituitary to be stored. And they are processed during this travel that they do. They are then transferred to the posterior pituitary, as we said, and get stored in hearing bodies, like that we discussed before. The secreting neurons are called magnocellular neurons. Magnocellular neurons. What else? Yeah. The hormones are carried with these, what I call, to represent as bodyguards. Okay. They are called neurophysins. And they protect these hormones while they are being transported. Okay. Neurophysin 1 is for oxytocin and neurophysin 2 is for ADH. This is the synthesis that happens. It's very, there's no need to remember. That's more a very general thing. Okay. DNA, the transcription, the translation, then this is the pre-pro hormone, and it's cleaved to give us the pro hormone. The pro hormone will be the hormone and neurophysin. And it's not important, and you will not be asked about it probably. Now ADH and it's the same thing. ADH and vasopressin, the other name. Now it has two receptors, and its effect depends on the receptor it binds to. You know one of its receptors, and you know its effect that we will discuss in a minute. But now let's talk about its other name, vasopressin. Why is it called vasopressin? Because it presses the vessels. So it's what? Vasoconstrictor. And it acts on these V1 receptors. Okay? Remember, V1 receptors are for vasopressin. Okay? They are found on vascular smooth muscle. And it acts by the IB3 pathway. That's what I want to know. IB3 mechanism. It causes vasoconstriction of arterioles to increase resistance, and it can use clinically during septic shocks rather than catecholamines. Because catecholamines, so for example, someone has low blood volume, right? And they have low blood pressure. So one thing that you can do is give them norepinephrine, right? Which is the sympathetic stuff. So they can have vasoconstriction. But the problem with this, I need to raise the blood pressure. The problem with this is that this vasoconstriction, this norepinephrine, other than doing vasoconstriction, it will affect the heart and start getting the heart to work even more. And this is bad because it will increase the myocardial O2 demand, right? Because then the heart itself will need more oxygen, and you can't afford that. So, but vasopressin, what will it do? It will come and vasoconstrict the vessels without affecting the heart. So it can be used during the septic shock. Now it has also, as we said, another receptor, which is the V2 receptor that you already know, which is found in late distal tubule and collecting duct, which is the ADH effect now. It's acting by the CAM pathway to release, it phosphorylates aquaporins too and put it in the cell membrane, leading to water reabsorption. So it will concentrate the urine and dilute the plasma. It's stimulated by high plasma osmolarity or low blood volume, because you will want to reabsorb water in both cases. Angiotensin 2 and pain and cis also. Here it's the opposite, low plasma osmolarity and high blood volume. And alcohol too. So alcohol is diuretic because it inhibits ADH. And natriuretic peptide also inhibits it. Now, diseases that are related to ADH are diabetes insipidus to start with. Diabetes insipidus is when you do not have ADH. It can come with three variants. Either central diabetes insipidus, which is the failure of the pituitary or the hypothalamus. Because it's central, the main problem coming from your central nervous system. So you will have low ADH and low urine osmolarity, high plasma osmolarity because you don't have ADH and so on. Nephrogenic diabetes insipidus is that the problem is in the receptors themselves. Okay? Like Laron dwarfism that we discussed. You will have high ADH because it's trying to compensate. I'm releasing ADH from the hypothalamus, but there is no negative feedback. I'm not reabsorbing anything. So it starts producing even more. And you will have all the same. Low urine osmolarity. Sorry, this should be high. Okay, I will edit it. Okay, and high plasma osmolarity. I will edit this. Sorry, guys. Now, gestational diabetes insipidus is excessive degradation of ADH by placental vasopressinase. This happens in pregnant women, and it's not very important. Now, SIADA, which is syndrome of inappropriate ADH secretion. Too much ADH, basically. And it can be caused by surgeries, infections, drugs, whatever. No one cares about the causes. But then you will have high ADH, high urine is... Why am I doing too many problems? Sorry, guys. This should be low urine... No. This is right. This is urine. Okay, so it's high urine osmolarity because you are absorbing all the water from the urine. You'll have low plasma osmolarity and low serum sodium. It's not how you write sodium. Apparently I was on something while doing these slides. Okay, the oxytocin, it has two main effects. Smooth muscle contraction, which is very important in labor. So we can give it to induce labor. And milk ejection, okay? It's stimulated by cervical and vaginal stretch, which is positive feedback. Suckling reflex, and it's positive feedback. Oxytocin is the major example for positive feedback. The cervical and vaginal stretch, basically when the woman is giving birth and the baby needs to come out, right? So we can't stop in the middle. We can't have negative feedback. You want this stretch to simulate even more oxytocin, to push even more. Does that make sense? The suckling reflex too, because you want the milk to continue releasing, because then if the baby, if we had negative feedback, once the baby starts drinking milk, it will stop suddenly because of the negative feedback. So both will be positive feedback. Estrogen and social bonding and emotional stimuli, it's the hormone of like to say that it's the hormone of love and the hormone of emotions and so on. It's inhibited by stress, sympathetic stimuli because of stress, and pain and anxiety. And so for some questions, please stop if you wanna, or pause if you wanna solve it yourself. It's B, severe hypophysiology, because this is Sheehan syndrome, postpartum bleeding. So of course it will be Sheehan. Now, the answer is corticotropes. Because as we said, this is POMC. Okay, this is the full name that no one knows. But yeah, okay. And the answer is C, somatotropes. Because of as I said, once you see this, facial features are different or whatever, you know that they want to talk about the acromegaly probably. Yeah, coarse facial feature. Now for the thyroid gland. For the anatomy, it's basically two lobes that are united in the center by this isthmus, okay? And in 10% of people, they might have this third lobe, which is a pyramidal lobe that extends from the middle upwards. Now, the thyroid extends from the thyroid cartilage and downwards to the sixth ring of the trachea almost. The isthmus that's connecting them lies at the level of the second and third trachea ring, approximately. For the also here we have the fascias that are covering the thyroid. It's covered by two fascias. A true one that covers the gland itself, like a capsule, and a false one, which we call pretracheal. From the name, it's connected to the trachea. So when someone swallows, the thyroid will move because it's connected to the trachea, which will move with swallowing, you know. So if a tumor is found in the neck, you will tell the patient, swallow please. If the mass moves while he's swallowing, it's most likely in the thyroid. If it doesn't move, no, it's not in the thyroid, because then it would have moved, if that's the case. For the relations, okay, the carotid arteries and internal jugular veins are posterior-lateral. It covers the trachea and esophagus like a shield. Anterior to it, we have two muscles that are anterior to the thyroid. Sternohyoid and sternothyroid. So if a surgeon is approaching the thyroid, he will need to at least move the muscles away. We have 4 small parathyroid glands that are embedded within the thyroid capsule itself, and they secrete parathyroid hormone to raise calcium levels. Nothing more you need to know about parathyroid for now. The blood supply, it's mainly supplied by 2 arteries. Like we had superior hypophyseal and inferior hypophyseal for pituitary, here it's superior thyroid and inferior thyroid. The superior thyroid will supply the upper part, and the inferior thyroid will supply the lower part. Sometimes a third medial artery is found in 10% of people. That will be in the middle. And it's called thyroid emma. It could be from aorta, brachiocephalic trunk, internal carotid artery. But it can be, what I need you to know is that it can be accidentally cut during tracheostomy, because people do not put it in mind, because it's all in the 10% of people. But when you want to cut the trachea, as you can see here, okay, the artery will be like this. So you might cut the artery by mistake. So that's something that you should keep in mind. Now, also another note that you have to keep in mind, and it's asked about, they ask about it a lot. Close to the superior thyroid artery's origin. Okay. By the way, the superior thyroid is a branch of external carotid, while the inferior thyroid is a branch of the thoracocervical trunk. It's coming from the subclavian. It's all memorization. But what I need you to know is that close to the origin, we have the external laryngeal nerve. If you want to ligate the artery and you go to the origin, you will ligate the nerve by mistake. So it's better to go towards the thyroid gland itself, like away from the origin of the artery and towards the gland, and to ligate it there, away from the nerve. If the nerve is ligated, it will lead to voice change and monotonous voice. Now, to the inferior thyroid artery, here it's the opposite for the inferior thyroid artery. Near the gland itself lies the recurrent laryngeal nerve. So if you want to ligate it, will you go towards the gland? No. You will go towards the origin of the artery. And it will lead to hoarseness of voice if you ligate it. Okay guys, so for the venous drainage, I'm sorry, this slide was cut from the original file, so I had to record it on its own. So the venous drainage, the thyroid is drained by 3 main veins. It's very easy to remember, nothing special to memorize. Just know that the superior and middle thyroid vein, first of all, they are superior, middle, and inferior. Superior and middle will drain into anterior and jugular together, and inferior thyroid will drain into the brachiocephalic veins. On the corresponding side, of course, you have right and left and so on. Okay, now back to the lymphatic drainage is simple. Pre-laryngeal lymph nodes receive it, give to pre-tracheal, so laryngeal then pre-tracheal. We reach the trachea, right? So it's paratracheal now, and then deep cervical. Now the embryology. We'll start with the pharyngeal arches to understand the parathyroid gland's origin. Around the 5th week of the embryo life, okay, in the neck region, you will have something weird. What we call pharyngeal arches will start to appear. There is 6 of these arches. Now, I want you to look at these arches, okay? These are the 6 arches that we will have. In the middle of them, we will have mesoderm. While in the inside, you will have endoderm, and outside, you will have ectoderm. Inside, these depressions that are inside, we call pouches. And outside the ectodermal stuff, we call it clefts. Okay? Now let's see what happens for each of these. For the clefts, they are ectodermal, outside, superficial, whatever you want to call them. Initially, they are 6, but then the 5th and 6th will disappear. So we will only have the first 4. The first one will give us the external auditory meatus, basically your ear from outside. Now, the second, the third, and fourth, what will happen? The second will overgrow the third and fourth. So it will grow and cover them. And they will fuse to form one thing. What is this thing that we just formed? It's the neck. Didn't we say it's in the neck region? Why is your neck smooth? Why don't we have depressions? Because of this fusing. Now, the pouches, they are endodermal, inside, internal structures, basically. We have 6 pouches. 5 and 6 disappear. 5 not really, we'll see in a minute. But let's just say that for now. So we have the first 4. The first cleft gave us the external auditory meatus, right? Here, the first pouch will give us the internal auditory meatus. Parts of it, at least. For example, the auditory tube. Okay? The second will give us 2 palatine tunes. The third will give us 3 structures. The thymus and 2 inferior parathyroid glands. The fourth will give us the 2 superior parathyroid glands. Now wait a minute. Something here is weird. Why is the superior parathyroid gland coming from the 4th pouch, which is below the inferior parathyroid gland, right? Well, I'll tell you why. The thymus is coming also from the 3rd, right? With the inferior parathyroid, right? It will descend down towards the chest and it will pull the inferior parathyroid glands with it. So it will be below the parathyroid gland, the superior parathyroid glands. Now for the 5th, we said it disappears, but not entirely. A part of it proceeds and it's the ultimobronchial that are coming from there. What are these? They give rise to parafollicular cells of the thyroid, which are calcitonin cells that we will see in histology. Okay, this is a summary. Now, what about the thyroid? You know the foramen cecum? Here, let's come here to the thing that we saw in GI. This is the anterior portion of the tongue, and this is the posterior portion of the tongue. And as you can see, in between them, you have this foramen cecum. Can you see? In this foramen cecum, the thyroid gland starts forming here in the embryo. So it was not originally in the neck, it started in the tongue. And this diverticulum that starts forming is called thyroglossal diverticulum. The thyroglossal diverticulum, or what we call also the thyroglossal duct, it will grow downward and towards the neck. And it descends anterior to the hyoid bone and larynx and divides into two lobes. It's initially connected to the tongue, right? As we said, by the thyroglossal duct. But then it loses this connection in 7th week and the thyroglossal duct will disappear. What's only remaining from this thyroglossal duct will be the foramen cecum. Does that make sense? Okay. As you can see here, it descends down. Now we will have some anomalies that might happen because of this descent of the thyroid gland. You might have congenital hypothyroidism because of problems in development of thyroid. This is not what we're gonna talk about mostly. But here we have thyroglossal duct cysts and sinuses. Some remnants of thyroglossal duct might be left along the midline, along the thyroid descending pathway. Okay? And these are only cysts, they are not functional thyroid at all. Now you might have ectopic thyroid tissue, which is maybe lingual, the most common one, or sublingual or subhyoid, along also the pathway of descent. And it can be the only thyroid tissue present, which is important because you don't want to remove it, because then the person will not have a thyroid gland at all. Okay, if that's the case. But you might have accessory thyroid tissue, which is related to the thymus mostly. Okay, which is how is different from ectopic. The main difference that you have to keep in mind is that accessory thyroid tissue is accessory. It's not functional enough and it does not provide a big function, so you can remove it. But you need to differentiate between it and the ectopic because the ectopic might be the only thyroid tissue present. Agenesis of the thyroid, the entire gland or lobe might be gone. If it's only one lobe that's gone, it's mostly the left one. By mistake, okay, whatever. As you can see here, the thyroglossal cysts, it can be above the thyroid cartilage. Okay, it can be above the hyoid bone or below it or below the tongue. Not very important. And let's go for the histology. The capsule is dense irregular connective tissue like any capsule that you've seen in your life, and it dips into the thyroid gland itself to subdivide it into lobules. So first we have lobes, then lobules. Each lobule has follicles. Each follicle has colloid fluid inside, in the middle, and one layer of cuboidal cells that we call follicular cells. They are the cells that are responsible for releasing the thyroid hormone, as you can see, T3 and T4. Now they are cuboidal in shape, as we say, but they can appear squamous when inactive or columnar when active. Another set of cells that you can see is the parafollicular cells that we have talked about, in embryology, that are coming from the ultimobronchial bodies, and they secrete calcitonin, which decreases calcium levels. Now the thyroid gland histology also, as you can see in the pictures, basically these are the follicles, and these are the septas, which are the connective tissue that dips down to divide into lobule. This is a whole lobule. These are the follicles, each one of these tiny stuff. And this is an inactive follicle. As you can see, it will appear squamous, and active follicle might appear more columnar to cuboidal. It's not a white or black thing, okay? It might be a bit gray, you can differentiate very well, but keep it in mind. So for the thyroid hormones, when we are talking about them, we are talking mostly about two hormones, okay? T3 and T4. T3 is called triiodothyronine. T4 is called thyroxine. What are they? They are basically one tyrosine amino acid with a number of iodine molecules attached to it. Either 3 or 4. If it's 3, it's T3. If it's 4, it's T4. basically. Now T4 is 90% of the produced hormones, so we mostly do thyroxine. But T3 is 4 times more potent. It's stronger effect. So when the cells get the T4, they will turn them into T3 by the enzyme 5-deiodinase that we'll discuss also in a minute. But why do we produce T4 then? Let's just produce T3 since it's more potent and we want it clearly. No, but then T4 has longer half-life, so it can remain and be stored more than T3. And this you can see here. T4 has a longer latent period, and its maximum activity will be reached later, so it's less potent, but it has longer half-life. And it's the opposite for T3. Now, to make the thyroid hormone, as we said, we need a tyrosine, and we need to attach iodine to it. Tyrosine is formed in the cells in the form of thyroglobulin. Okay, so these thyroglobulins are basically 70 tyrosines per one thyroglobulin that are connected together, and just a bunch of tyrosines that we want to attach iodine to it. Okay, so now we have our tyrosine. What about the iodine? The iodine comes from the diet in the form of iodide, not iodine, but iodide. This is important because we'll see how or what will we do to make it iodine. Now, if we have a tyrosine and one iodine, we call it monoiodotyrosine, or MIT for short. Tyrosine 2 iodines, diiodotyrosine, or DIT for short. Tyrosine 3 iodines, triiodothyronine, which is T3, tyrosine 4 iodines, T4. So, let's see what we do. We want to get our iodine from here, but it came from that as iodide. You see, this iodide? We want it to be iodine, this thing. So what will we do? First of all, we will trap it in the cell. This is the follicular cell, by the way, of the thyroid gland. And to trap it, we will get it into the cell together with a sodium molecule by this channel. So we get our iodide, right? Now this iodide will go out of the cell towards what's on this side? The colloid fluid that we discussed in histology, if you remember. This is inside the follicle. So what will we do? We will throw it out in exchange of chloride I think blue will work better here. Yeah. In exchange of chloride by this channel that we call pendle or whatever. Now we got our iodide here. Wait, it became iodine. What happened? There's this enzyme here that's called peroxidase that turns this iodide into iodine. Okay, that's cool. Now we have our iodine. Now what? We will attach it to the thyroglobulin that's already found here. It will give us mostly MIT and DIT. Then we will, when we have our MIT and DIT, we'll do something that we call coupling. Okay? This coupling is happening how? I will tell you. Basically, you have one MIT which has one iodine, right? And for example, one DIT which has 2 iodines. You couple them together to have 3 iodines. So now you have what? T3. Or you couple 2 DITs to have 4 iodines. So you have what? T4, and so on. Now, the final thyroglobulin will have either MIT attached to it, or DIT, or T3, or T4. We won't talk about this, okay? The doctor said it's not important. Anyways, so it goes into the cell by pinocytosis, and we have these enzymes called proteases. It will take the T3 and T4 from the globulin, the thyroglobulin, and secrete it because it's already ready. What about MIT and DIT? They are not ready. They are not functional. What do we do with them? We cut them by the enzyme deiodinase. It's different than the one found in the cells, okay? But whatever. Now we cut them by an enzyme called deiodinase into tyrosine and iodide, again. And we repeat the steps. Tyrosine will go to the thyroglobulin and iodide will go out of the cell. And this is how we synthesize. As you can see, we will trap the iodide first, then we oxidize it by peroxidase. Okay? It leaves the cell or whatever. The thyroglobulin binds to the iodine by peroxidase. The coupling is happening also by peroxidase. So peroxidase is responsible for 3 steps. The oxidizing of iodine, the organification of the thyroglobulin, which is attaching the iodine to thyroid gland, and the coupling. These 3 steps are all mediated by peroxidase. And this is important, please. This is the most important point here. Now, as we said, we will have these MIT, DIT, T3, T4. We'll take what we want and then recycle the other stuff. Now, this is what we just said. But then, this is why it's very important. Because BTU, which is this drug, propyluracil or whatever, BTU, it inhibits peroxidase. So it's an anti-thyroid drug because it will impair 3 steps of the thyroid hormone synthesis. It also inhibits the 5-deiodinase, the one in the cells, if you guys remember. And this is, as you can see, this is the summary. These drugs will inhibit iodide trapping. These will inhibit the binding. I want you to remember PTU, it's the most important one. And endocytosis will be impaired if you have high concentration of iodide, because everything is regulated within a normal range. Even though you want iodide, but if you have too much, it's bad. Now, what are the effects of TSH? TSH increases T3 and T4 synthesis. But how? Increases proteolysis of stored thyroglobulin, increases iodide pump activity. It's basically making everything in the follicular cell work faster. Increases iodination of tyrosine. Anything that you can think of almost is basically mediated by TSH. It increases the work rate, basically. It also increases the number of thyroid cells. It changes the shape. It enlarges the thyroid gland. So it's promoting all of the thyroid activity. It uses CAMP mechanism, while TRH uses IB3 mechanism. Okay, and cold increases TSH, as we have discussed. These mechanisms, we will go back to it at the end of the whole thing, so no need to worry about them for now. This is the axis, the negative feedback one. We have, as always, negative feedback, where T3 and T4 will come back to inhibit TRH and TSH. And somatostatin, dopamine, glucocorticoids too, but to a lesser extent, they will also inhibit. And thyroid stimulating immunoglobulin, TSI, binds to TSH receptors to do the same effect. Why is that important? Just wait for me, bear with me for a minute, and I will come back to this information. But TSI does the same job as TSH. Where does it come from? Why is it important? Just a minute. Now, T3 and T4, this is their mechanism of action, basically. They are lipophilic. They can diffuse through the cell membrane, as we have discussed before. So they will diffuse, go to the nucleus, attach to this receptor, and they produce changes in gene expression. These are the effects of T3 and T4. They can be summarized in 7 Bs. They are basically the metabolism hormones. They will increase everything that has to do with metabolism. They are important for growth, for everything, almost the brain, maturation, the bone growth with the growth hormone. They have beta-adrenergic effects, so they increase the cardiac output. So everything is very active, very active. Think of it like that. The basal metabolic rate is increased. Blood sugar to break down of lipids, surfactant synthesis. Now, for the basal metabolic rate, I also want you to know that it has to do with the sodium-potassium pump, because it will increase this sodium-potassium pump work, so more ATP is being used, so more heat, and so on. Another effects that is not mentioned in the 7Bs one are some, basically it's hyperactivity for everything. You can see gastrointestinal motility will increase. The central nervous system will be very excited. The muscles will start being strong, but that's only for a short period of time. It will be weak after a long time. You will have muscle tremor. As I said, everything is very active. It's affecting endocrine gland also and sexual function. Maybe you just know this. Hypothyroidism leads to decreased libido. And hyperthyroidism results in impotence. So neither this or that is good. Okay. Now let's talk about the diseases, which are the biggest part of this lecture, thyroid, that you will be asked 100% about. Hyperthyroidism. Symptoms, think of high activity. All of these symptoms are high excitability, blah, blah. No one will ask you about them. But just when you see a very active person in the question okay, with the intolerance to heat, diarrhea, blah, 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 yeah, you know that this is hyperthyroidism. And one special sign that you will see here is exophthalmos, which is the protrusion of the eyeball. Do you see this lady's eye? This is a very known sign for hyperthyroidism. It's very important. And they will have peritibial edema. But just know the exophthalmos, okay? What are the causes? It can be due to Graves' disease. It's an autoimmune disease with high levels of TSI. Do you remember? Do you know now why I talked about TSI? Because TSI binds TSH receptors. So it leads to high amounts of T3 and T4. So you have hyperthyroidism. What about thyroid adenoma? It's a cancer of the thyroid gland that will secrete a lot of T3 and T4. So of course TSH will be inhibited because you will have high amounts of T3 and T4. So that causes the parts that does not have cancer to have atrophy rather than enlarging. Why? Because TSH is the one maintaining the size of the gland. The cancerous part will grow by itself, but the one that doesn't have cancer will have atrophy because you don't have TSH. What are the lab findings in hyperthyroidism in general? When you talk about primary hyperthyroidism, high T3 and T4, low TSH because of negative feedback. You will have high TSI if it's Graves, which is the determinant factor for Graves. Hyperthyroidism is generally associated with small thyroid because of low TSH, except for Graves. Why? Because TSI binds to TSH receptor. So it does the same effects, even the trophic one. So it will enlarge. The treatment could be radioactive iodine to demolish the gland, surgery, BTU, as we say, because it's an antithyroid drug. Hypothyroidism is the complete opposite. Low activity, very low activity. Think of it this way. Fatigue, slow heart rate, constipation, all of this. And the special sign for this one is called myxedema, like the exophthalmos there. Myxedema is, as you can see, the bagginess under the eyes and the filling of the face or whatever. This is called myxedema. It's mostly seen in complete absence of these hormones. Not in the case, but in complete absence, it becomes clear. Now, hypothyroidism, what are the causes? Hashimoto's disease is the most important one. It's an autoimmune disease like Graves, but instead of secreting TSI that stimulate the gland, it will secrete antibodies that destroy the gland. So you will have low T3 and T4. And you will have high TSH. So what? You will have enlargement of the thyroid gland because TSH will come and enlarge it. Okay? Hypertrophy of the thyroid gland. That could also lead to be a cause of a sign of hypothyroidism. It could be either because someone for example does not take enough dietary iodine, which is called endemic goiter, or it could be just idiopathic. And this idiopathic one comes mostly from thyroiditis. The main thing here is just no Hashimoto, and dietary iodine is also good to know. The lab findings will be low T3 and T4 and high TSH because it's trying to compensate. What's the treatment? Take thyroxine. Okay? As you can see, any impairment in any step in the pathway would lead to hypothyroidism because you won't synthesize the hormones. And yeah, these are the kind of goiters that you'll have. When you say goiter, it means large thyroid. And it's mostly associated with hypothyroidism because they have high TSH. Except, as we said, for Graves' disease, which is hyperthyroidism, but it's also goiters. It can be either smooth or nodular, but I doubt he will ask about such a thing. Cretinism. This is a condition where a baby has low thyroid hormone. Unfortunately, they will present with mental retardation because thyroid hormone is very important for brain development. So if a baby has low thyroid hormone and it's not detected right away, after a few months, he will present with mental retardation. But what if it's detected right away? It's very easy to treat because just thyroxine oral intake or any supplements, it will solve the whole problem. Okay, like it was nothing. So this is why it's actually mandatory, I think now, that each baby that's born has to have their thyroid hormone levels measured right away. Because if the baby has a problem, we can solve it right away. before it's too late. Yeah. Questions? This will be A, change in voice quality, because this is the, it says superior thyroid artery, what was close to it, external laryngeal nerve, which will cause change in voice quality and monotonous voice if injured. It's D, because as we said, PTU inhibits the 3 steps that we have discussed, and also the deiodination by deiodinase, or 5-deiodinase in the tissues. Okay. This is also D. As you can see, he had elevated thyroxine and low thyroid stimulating hormone. So this is what? Hyperthyroidism. Okay? His thyroid was smaller than normal, and this is the very important one. Because look, when we say hyperthyroidism, we already took these out. So it's either D or E. But his thyroid was small. Graves present with goiter, big thyroid. So it will be D, the only one that's works. Adrenal gland. It's very easy, inshallah. It will be also a short one. So for its anatomy, it's bilateral, yellowish retroperitoneal organs that are superior to the kidney within Grotta's fascia. I like to think of them as kidney's hat. You can see as if it's wearing a hat. Yeah, this is the adrenal gland. And the right adrenal is more triangular in shape, so it comes on the apex of the kidney, like this. Okay? The left adrenal, on the opposite, is more crescent shaped. So it's in the top, but then it kind of descends down to cover the middle of the kidney, if that makes sense. Okay? And they are generally divided into cortex and medulla. When we talk about the adrenal gland, we will see when it matters, inshallah. Now, the relations. The right adrenal has anteriorly the inferior vena cava and liver, posteriorly the right cross of the diaphragm. Left adrenal has anteriorly pancreas and stomach, posterior left cross of the diaphragm. The posterior relation is easy to remember because it's the corresponding cross of the diaphragm. Anterior relation, just think that the right adrenal is in the right. What do you have to right in the abdomen? Liver and in IVC, and in the left pancreas and stomach. The left also is related to the spleen and splenic vein. I want you to keep the splenic vein in mind. When you look at it this way, it makes sense, right? The right adrenal will have the IVC in front of it and the liver. And the left adrenal will have the pancreas, and anterior to the pancreas is the stomach, and also the splenic vein will be a bit anterior to it. As you can see here in the CT scan, these are the adrenal glands. They look usually in CT scans like triangular thing. I like to think of them like spinners that we use to play with, if that makes sense. Now for the blood supply. It's also very easy. The arteries coming from 3 sources: superior, middle, and inferior suprarenal. Because that's the other name, of course, of the adrenal gland. The superior suprarenal is coming from the inferior phrenic artery. Think of it that inferior phrenic artery is supplying what? The diaphragm. The diaphragm is above. So it's superior suprarenal. Middle suprarenal coming from the aorta, and inferior coming from the renal artery. The venous drainage will be easier because then it's one vein. It's not 3 veins like the arteries. The right vein of the suprarenal gland will drain directly into the IVC, while the left one will go first to the left renal vein and then to the IVC, as we have studied in renal. Lymphatics, the drainage happens to the para-aortic and paracaval lymph nodes. Now, the adrenal gland is divided into 2 main parts, as we said, cortex and medulla. Zona glomerulosa, zona fasciculata, zona reticularis are the divisions of cortex. We will talk in details about them when it matters. But for now, I want you to focus with me on the blood supply that's inside the gland. What happens inside the gland? In the capsule of the gland, the 3 arteries that we have discussed, they join together and they give some branches. The point is that we will have this capsular artery. We said that we have a cortex and a medulla, right? So the capsular artery, it makes sense for it that it gives 2 branches, one to the cortex and one to the medulla that's going directly to it. The medullary one is easy, nothing special about it. But look at the cortical one. It comes here and it branches here in the zona glomerulosa to give us this capillary plexus. And it descends down to join the venous plexuses of the medulla. So the blood that's coming from the cortex will pass by the medulla. Why? I'll tell you. Here in zona fasciculata, we secrete a hormone. It's called cortisol. Why is cortisol important? Why do you want it to pass by the medulla? I'll tell you why. Here we have some cells in the medulla that are called chromaffin cells. These are basically modified neurons, and they are modified to become endocrinal cells. Cortisol is what keeps them at this state. If we don't have cortisol, they will turn into neurons. So if you take them out of the medulla and you put them in a petri dish or something, and you keep them growing in there, they will become actual neurons. And you don't want that to happen, okay? They are chromaffin cells and they are in the medulla for a reason. Please stay endocrine, okay? Now, other function of cortisol in the medulla is to turn norepinephrine to epinephrine. You know that we have two hormones here, right? Norepinephrine and epinephrine. Epinephrine is the main secretion. So even if you have norepinephrine, you would want to convert it to epinephrine. And that's happening by the help of cortisol. The last thing that I want you to keep in mind about the blood supply is this central adenomedullary vein. This guy. It is very thick and strong. The tunica media is very strong. And its fibers are parallel to the gland. Why is that important? Because when we dump the blood here, it contracts. And when it contracts, it's like it's squeezing the whole gland to pump the hormones inside. So when we have hormones, it will squeeze the glands towards it to have the hormones going to the blood. These are the three things that you should keep in mind. Now for the embryology. Very easy. The cortex is, we have two parts of the gland, so we'll have two embryology. Okay, we'll have two origins. The first one for the cortex is derived of the coelomic mesoderm, which is next to the urogenital ridge. It's the part where we get the kidney and the gonads from, if you remember, from the renal block. So I just want you to remember coelomic mesoderm. Between weeks 4 to 6 of gestation, by week 8, this cortex will not be just cortex, it will be two. One, which is thin outer, definitive cortex. Definitive means it's permanent. And a thick inner fetal cortex. The inner one is what functions during gestation. And while the baby is in his mother's womb, you will have this fetal cortex producing the hormones. The definitive cortex becomes the functional adult cortex after birth. And the fetal cortex will disappear. Okay? So we'll only have the definitive cortex. Now, zona glomerulosa and zona fasciculata of this cortex will be present at birth. But if you cut the baby's adrenal gland right after birth, you will not see the reticularis zone. Why? Because it develops during first year of life. The baby is not born with the zona reticularis. Now for the medulla, it's derived from neural crystals. Okay, very easy since it's, as we said, it's similar to neurons. And it develops alongside the sympathetic nervous system. So the medulla is a modified sympathetic ganglia. And in week 5, these cells will descend down and migrate to the right and left, which we call para-aortic or paravertebral regions, because they are next to the aorta. And they go toward the medial aspect of the developing cortex. So they go inside the cortex to form the adrenal gland. As you can see, this is the neural crystals, and they will come here down next to the aorta, and they will migrate towards the cortex. And this is the thick cortex that we have talked about with some medulla, and then it disappears when the baby is born, and we will only have the actual cortex with the medulla. Now for the histology. Zona glomerulosa is, as you know, the outer one. The fasciculata is the middle, and the reticularis is the inner one. For glomerulosa, it's composed of small cells with intermediate lipid inclusions. Not many, not little, okay? And it's spherical in shape. It's ball-like arrangement. This is why we call it glomerulosa. Do you remember the The one in the renal, guys, the one in the kidney, okay? Sorry, I'm fasting and I'm recording this in the morning and I can't pronounce stuff, okay? Now, this is why we call it glomerulosa. Now, fasciculata is the largest zone and it makes up 75% of the cortex almost. And its identification point is these large foamy cells. They have a lot of lipid inclusions, so they will appear whitish. Zona reticularis is the smallest cells, and it has the smallest cells, and it has the lesser amount of the lipid inclusions, so they appear pink or dark in color. As you can see, like when you look at it in macroscopic look, you will see that you have these zones, okay? And when you look at it in the microscope, this is the adrenal gland. You have this cortex, and in the middle you have the medulla. The medulla appears darker, but that's here in Dr. Yaqeen picture, because in our lab, I wanted to know that scientifically, yeah, it should be darker. But for some reason, in our lab, so please you don't mix it up in the OSB, it's kind of looks even more pale than these guys, so for some reason. Now the histology, you can see here, this is the capsule, okay? And the first part will be zona glomerulosa, which is, as you can see, like balls, a lot of balls here, and there. And then you will have very whitish thing that's like columns, and this is the zona fasciculata, can you see? It's very large. Now here you can see the zona glomerulosa, as we said, zona fasciculata, the whitish guys that are big in size. And after you'll have zona reticularis, which looks very pinkish, as you can see, with almost no lipid inclusions. So now let's talk about the adrenal gland, but in physiology. Starting with the cortex, as we said, you have zona glomerulosa. What does it secrete? Mineralocorticoid, okay? And an example of that is aldosterone. Zona fasciculata, which secrete glucocorticoids, and it's mainly cortisol. It can produce some androgens, but to a lesser extent, so it's not the main one. Zona reticularis gives us the androgens, which has mainly DHEA, and it can produce some glucocorticoids, but to a lesser extent. So these guys can crisscross sometimes, but not mainly. The main secretions, you know it now. Now, how do we synthesize these hormones? All of the adrenal cortical steroids are chemical modifications of cholesterol. So we start with our cholesterol. And then we do some modifications to it. And according to what modifications we do, we get our steroid. Now, cortisol is basically the modifications that we have to keep in mind is the ketone group at the carbon number 3 and hydroxyl groups at carbon 11 and 21. Please remember these two, carbon 11 and carbon 21. Now, mineralocorticoids, like aldosterone, they will be same as cortisol, but we will have double bond oxygen at carbon number 18. Not very important. This is the most important part, okay? Androgens like DHEA and androstenedione, okay? They have double bond oxygen at carbon number 17 rather than 18. And they lack the C20 and 21 sided chains that are in glucocorticoids and mineralocorticoids. Now, okay, we said we start with cholesterol. Where do we get our cholesterol from? It comes from lipid droplets from cortical cells. These cortical cells, didn't we say that they have lipid droplets when we were talking histology? Okay. We will have these droplets. We have low density lipids inside of them. Low density lipids have cholesterol esters. We modify it and we get our cholesterol. Most of the used amount will be recycled, okay? Most of the fat or the cholesterol will be recycled, but any amount that we will lose or excrete from the body, it will be replenished by low density lipids that are coming from diet in the blood. It goes into mitochondria after we get our cholesterol by star transport. So cholesterol enters the mitochondria and it starts being processed. Now, I want you to know that the hormones are not stored. They are synthesized when you want them. And they are rapidly secreted right away. And they are bound to plasma proteins because they are hydrophobic. Now, yeah, this is, as you can see, the adrenals hormone synthesis. The first step, and it's the rate limiting step, and it's the shared step among all corticosteroids. They all start the same way. Is the conversion of cholesterol to pregnenolone by cholesterol dismolase. This is the enzyme, the rate limiting enzyme. So as you can see, its other name is cholesterol side chain cleavage enzyme. Why? Look at cholesterol and look at cortisol, for example. What's the difference between cortisol and this guy or whatever? Is that this side chain is cut, right? So this is why it's called side chain cleavage. Now we take the cholesterol and we cut its side chain to produce pregnenolone, as I said. Okay, now let's take this pregnenolone and see how do we turn it into cortisol. This is the pathway. We have our pregnenolone, right? By the enzyme 17-alpha hydroxylase, we'll turn it into 17-hydroxypregnenolone, because this 17-alpha hydroxylase, right? So it gives this hydroxy group and it's pregnenolone. By 3-B-hydroxysteroid dehydrogenase, we'll turn it into, I know it's big names, but please remember them. 17-hydroxyprogesterone. So we turn pregnenolone into progesterone by this enzyme. Whether it's hydroxylated first, or we can turn it right away into progesterone and then shift it towards cortisol synthesis. Okay? But the main thing is that this enzyme will turn our pregnenolone to progesterone, whether it's hydroxylated or not. Now we have our progesterone, the hydroxylated one. Do you remember when we said that we have hydroxyl groups at carbon 11 and 21 for cortisol? This is why I told you to remember it. Because we will have our 21 beta hydroxylase giving us the 21 hydroxyl group, and 11 beta hydroxylase giving us the cortisol. This is a summary. Please stop for a minute if you want to take your time with memorizing. I try to summarize it as much as I can. Now, I want you to look with me at the full picture for a second. I had covered this before, but I want you to look with me here, because we have here what we call corticosterone. When we want to go towards aldosterone, we'll have something called corticosterone in the middle as a precursor. Okay? Why is that important? Because corticosterone is another molecule that has glucocorticoid activity. It's not only cortisol. It's the main one. But what if we don't have cortisol? Corticosterone can cover for it, okay? And yeah, this is why if we have a blockage at the 17-alpha hydroxylase step, if the blockage is here, you will not have cortisol, but you will not die. Why? Because we don't need this to have corticosterone. So we can maintain life by corticosterone, because then the pathway will go through this. But what if we have, for example, a blockage here? We will not have either cortisol nor corticosterone, and now it does not work. I mean at this step, the 11 beta hydroxylase. And we'll discuss it in detail later. Now, there is some medications like metirabone, which inhibits 11 beta hydroxylase, or ketoconazole, which inhibits multiple steps, that can be used as an antagonists. Now, for androgen synthesis, it's similar, but what we will do is, now we got our pregnenolone and we shuttled it towards cortisol, right, by 17-alpha hydroxylase. We will do another shuttle here to get our DHEA that we were talking about, and by an enzyme called 1720 lyase. This is the only thing you need to know. It will go, and it will start continuing this way, but that's the main thing, that we shuttle it towards the androgens by this enzyme. Now, androgen synthesis, I also want you to know something about androgens, is that they have weak androgenic activity. They are not the main thing that gives us the androgen activity. When we say androgen activity, we mean the male hormones effect, male sex hormones effect. Okay, the main one is what? Testosterone. And in males, we since the testosterone will be synthesized aslan in the testicles. Okay, so we don't need them not at all, but we don't need them much. But for females, it's very important to have it because there's no testicles to produce testosterone. So it's the major source of androgenic compounds in females. Okay. Now, aldosterone. Aldosterone, as we said, we will always start by pregnenolone. Okay. And it will shift the reaction this way. It's gonna start this way. It uses the same enzymes that we've used for cortisol, except for 17-alpha hydroxylase, because we don't want to shuttle it this way. And we also have another enzyme that's important, which is aldosterone synthase. This is the one that gives us the final step, which is the last step after reaching the corticosteroid. Okay, so an extra step, let's say, than cortisol. I want you to keep in mind that aldosterone is not the only mineralocorticoid activity hormone, because DOC and corticosterone, these both have mineralocorticoid activity. So corticosterone has both glucocorticoid and mineralocorticoid? Yes, it does. Okay. Yeah. Now, this is why knowing that DOC has mineralocorticoid activity is important. Look with me here, guys. If we block the pathway here, what will happen to the mineralocorticoid activity? It will be demolished, right? Because we will not have DOC, we will not have cortisone, we will not have aldosterone, right? But what if we block it here? No, it will not be demolished, because then we will have DOC to cover up for us. Yeah. Just to recap, we start with cholesterol. We turn into pregnenolone by cholesterol desmolase. That's affected by ACTH. This is why ACTH is very important, because it activates cholesterol desmolase. If we want aldosterone, we'll continue with this pathway that we know. If you want cholesterol, we'll first shuttle it this way and then start using our beautiful enzymes that we have discussed. If we want androgens, we will shift this way after the first shift, which is by 1720 lyase. Aldosterone uses one more step than cortisol, which is the aldosterone synthase enzyme that's activated by angiotensin II. This is just a summary. Now the deficiencies. 3 main enzymes can be deficient or impaired. 17-alpha hydroxylase, if it's deficient, let's see what will happen. Let's just discuss it here and think together. So now we don't have 17-alpha hydroxylase. Will we have cortisol? No. Will we have androgens? No. So what will we have? A lot of this, because everything will be shifted this way. So as you can see, all cholesterol will go towards aldosterone. We'll have high aldosterone, low cortisol, low sex hormones, high blood pressure, because aldosterone will take the sodium and reabsorb sodium and water in the kidneys. Low potassium due to high aldosterone, also because it causes secretion. We'll see the effects later. In males, they will present with ambiguous genitalia and undescended testicles. Why? We have low sex hormones. Okay. Ambiguous genitalia means that you can differentiate whether that's a male or a female, because their reproductive parts are not developed well. In females, they will lack the second sexual development during puberty, also because of the sex hormones deficiency. Now, enzymes deficiencies. Also, we could have 21 beta hydroxylase deficiency, which is the most common one, and we call it also congenital adrenal hyperplasia. Let's see what will happen if we cut at the 21 beta. If you cut here, will you have mineralocorticoid activity at all? No, this is all demolished. Type cortisol, demolished. What's the only pathway that the reaction can go? This way, right? Towards what? Androgens. So you'll have high androgens and low everything else. Low aldosterone, low cortisol, high sex hormones. Low blood pressure and high potassium, because you have low aldosterone. In males, they present with salt wasting, high salt in the urine, because you're not absorbing it well. And they could present with precocious puberty during childhood. They might have their puberty at 7 or 8 years old. Can you imagine that? Because they have high amount of sex hormones. They might come at 10 years old with a full beard. Allah understand. Now, in females, they will present with masculine traits, which we call virilization. Okay? and that's because of the high sex hormones, especially the male sex hormones. 11 beta hydroxylase. Let's see what will happen now. 11 beta hydroxylase will cut here. Will we have any mineralocorticoid activity? Yes. This guy will maintain it. Aldosterone will be low, but this guy can do the job. What about cortisol? Gone. What about androgens? Yes, they are here. Sorry, I shouldn't have cut it here. Yeah. So androgens will be also high. So you will have what? You will have low aldosterone, high DOC, low cortisol, high sex hormones, high blood pressure, and low potassium due to high DOC. So and you will have the mineralocorticoid activity. And in females, they present with virilization, like we just said, because of the sex hormones. So the main difference between these two is that here we have DOC. So it will maintain the mineralocorticoid activity, leading to different symptoms. A summary, basically. Now, the regulation of synthesis. The synthesis and secretion depends on ACTH because it simulates cholesterol dysmolase. In the zona fasciculata reticularis, they are exclusively controlled by the hypothalamic pituitary axis, and CRH, ACTH, and all of these guys. They are what controls us because of the cortisol and androgens. But what about glomerulosa? It depends on ACTH for the first step. That's okay. But it's primarily controlled by the RAAS system, renin-angiotensin-aldosterone. So the key stimuli are angiotensin 2 and high serum potassium because of the last step, the aldosterone synthesis, if you remember. Okay. Now, for the cortisol secretion, it's secreted in pulsatile pattern. The lowest rates are evening hours, or about when you go to sleep. Highest rates will be just before waking in the morning, as we said. Why? Because of ACTH circadian rhythm that we have discussed. Now, ACTH, this is just a review. We have said this exactly in the pituitary one. CRH will simulate stress, hypoglycemia, circadian rhythm. This wasn't there because it was too much to say, but ADH slightly simulates ACTH. Inflammation too, inhibited by cortisol or its synthetic agonist because negative feedback, and some medications can inhibit it. This is the axis, as you can see. They go this way, and cortisol will inhibit both. This we have talked about in the pituitary, and this is something that I want you to keep in mind. Steroid hormones are taken by people to increase performance. Okay, these bodybuilders and so on, when they take steroid hormones, okay, they might take testosterone, for example, to build muscles. If they take too much, what will that do? They will stop secreting ACTH. But what will that lead to if you don't have ACTH? Because the negative feedback, will stop secreting ACTH. This will cause the gland to shrink, cause the atrophy of the gland. Because these pituitary hormones are what are responsible for the trophic effect, as we said, the enlargement, like the TSH for the thyroid, for example. So please do not take steroids. Now, mineralocorticoid regulation. As we said, stimulated by either decreasing blood volume or pressure, because you will activate the renin-angiotensin system. Low blood sodium, okay, because that will tell the aldosterone will come to reabsorb sodium from the kidneys. Okay, rising blood levels of potassium, because aldosterone leads to excretion of potassium. ACTH, but of course to a less extent, and inhibited by natriuretic peptide. This is the action of steroids. As we said, they go into the cell by diffusion, and they go towards either bind to a cytoplasmic receptor or to the nuclear receptor. These guys that we've talked about, they are all cytoplasmic, and they go to the DNA, bind to it, alter gene expression, and so on. Now the glucocorticoid functions. This is a summary for it, and we put it as cortisol is a big fab. A for appetite, increase appetite. B is for blood pressure, increases blood pressure, increases insulin resistance because it's a counter-regulatory hormone for insulin, increases gluconeogenesis, and so on, because as I said, it's opposite to insulin. You will have less fibroblast activity, so that you will have poor wound healing. It inhibits the inflammatory and immune responses, which is very important to remember, okay? Inflammatory and immune responses, because we give steroids to people with autoimmune diseases to inhibit the immune system. And it also decreases bone formation. So it has good effects and bad effects. So you don't want it to be too much, because this is why if someone takes a lot of steroid medications, they will have, for example, osteoporosis, right? Osteoporosis, because it decreases bone formation, and so on. Now, mineralocorticoid function. It regulates the electrolyte concentrations, as we said. It reabsorbs sodium, secretes potassium, and hydrogen ions, and water, of course, for the sodium. Where? In the late cell and collecting duct. How? By increasing the transcription of sodium-potassium pump and increasing the exhibition of apical sodium channels. This is all renal stuff, okay? Just know the effects. Cushing syndrome. We have discussed it before. This is the slide to remind you that we have excessive cortisol production, either by ACTH dependent. We will have high ACTH, high cortisol. It could be that means that it's coming from the pituitary gland or from ectopic place. ACTH independent will have low ACTH and high cortisol, because the main problem is coming from the adrenal gland itself, so it will come and inhibit the ACTH, either for adrenal adenoma or exogenous glucocorticoids, and the symptoms as we have discussed. This is the new part that I did not discuss in pituitary. How do you know which one of these is the reason? Let's see. First of all, you will give a low dose dexamethasone. This is basically a powerful cortisol. Once you give the cortisol, okay, it's low dose. If it gets suppressed, the ACTH is suppressed. Okay, now focus with me. What does that mean? It means that the ACTH is normal, because this is what you are expecting, right? To have no suppressed ACTH due to cortisol. Negative feedback is working, right? So this will be ACTH independent, because ACTH is normal. You don't think of it. It could be exogenous glucocorticoids or adrenal. What if ACTH is still elevated after cortisol? That means the negative feedback is impaired. This means the problem is coming from the ACTH. Okay, now it's from the ACTH, but how do we know? Is it an ectopic part, or it's coming from the pituitary gland itself? Because as we said, small cell lung cancer loves to secrete ACTH for some reason. How do you differentiate? I'll tell you. You will give high dose dexamethasone, so you'll give even more. If this suppresses it, this means that it's the pituitary gland. Why? Because pituitary gland has receptors for that, to tell it to stop. But if there is no suppression even after the high dose, then it has to be ectopic ACTH, because this means basically that these cells are different than the normal cells that we always deal with when we talk about ACTH. They do not respond to cortisol at all. Also, you can have CRH simulation tests. If it's simulated, that means it's normal pituitary cells. So it will give us will say, okay, give us MRI for the pituitary to make sure. If it does not simulate it, this means that, okay, these cells are different, which means that it's ectopic. Now, the diseases that are associated with aldosterone, if you don't have at all, it's death, basically. What about hyperaldosterone? It will have hypertension, right? This is not how you write aldosterone. Okay. Now let's start with adrenal insufficiency. People who do not have aldosterone and cortisol too, but it's mainly aldosterone that we'll talk about. Primary adrenal insufficiency is basically Addison disease. And they will not have aldosterone nor cortisol, but they will have what? High ACTH, because the problem is from the adrenal gland itself. If they have high ACTH, they will have high MSH. So they will have what? Hyperpigmentation. So these guys will present with hyperpigmentation. And they will have, of course, hypotension. Yani just reverse the effects of aldosterone and you will get the symptoms. Secondary adrenal insufficiency, it's the same symptoms but without hyperpigmentation and without hyperkalemia. Why? Let's start with no hyperpigmentation. It's because the main problem here is from the pituitary gland. You have low ACTH, so low MSH, so no hyperpigmentation. But why no hyperkalemia? Did I say hyperkalemia? Whatever. Why no hyperkalemia? Because aldosterone is not much affected, because the problem is from ACTH. And who regulated aldosterone the most? Angiotensin system, renin-angiotensin aldosterone axis. So this will be okay, so we don't care. Our tertiary adrenal insufficiency is from the treatment. Tertiary from treatment. It's seen in patients with chronic steroid use, okay? For example, if they have an autoimmune disease or whatever, and they cut it like at once, they will have this problem because the ACTH is already suppressed, and now you cancel the only cortisol that was given, or aldosterone that was given, or whatever. Sorry, the cortisol. Aldosterone is mainly affected because it's not affected by ACTH mainly. Okay. Now, hyperaldosteronism or Conn's syndrome. If it's primary, you have high aldosterone. If it's primary, it means the problem is from the adrenal gland, maybe adrenal tumor or something. You will have very strong aldosterone effects, whatever. And you will have low renin because aldosterone will inhibit it. Right? Because then, this is the aldosterone axis. It's not with the ACTH, but rather with the renin because it's the main thing. The secondary hyperaldosteronism, same thing, but instead of it being the pituitary, who are regulated the aldosterone? ACTH. So, sorry, not ACTH. Angiotensin, right? So the main one that will contribute to secondary hyperaldosteronism will be the juxtaglomerular cells, which are basically the ones that secrete renin. Okay, so they will secrete renin, so more renin, more angiotensin, and more aldosterone, so you will have hyperaldosteronism. But the problem is not from the aldosterone itself, but rather from the renin system. Now the medulla. The medulla is similar to a sympathetic ganglia. Okay, the sympathetic neurons will go to the medulla, synapse on the cells, and they will secrete epinephrine. Mainly, 20% of them will secrete norepinephrine. Now remember that norepinephrine, if you want to convert it to epinephrine, you will need to methylate it by the help of cortisol. As you can see, it's coming, synapses, and then it secretes from the cells, the chromaffin cells. Now the receptors, let's start with talking what are catecholamines. Catecholamines are basically norepinephrine and epinephrine. How are they synthesized? They are derived from tyrosine. The rate-limiting step is the conversion of tyrosine to L-DOPA. As you can see, tyrosine will become L-DOPA, and dopamine, then to dopamine, and then norepinephrine and epinephrine. Now, as we said, cortisol is what helps converting it. For the metabolism, catecholamines are degraded by this enzyme and this enzyme. I want you to remember this part especially. The final metabolite of norepinephrine and epinephrine is vanillyl mandelic acid, VMA. This is the buzzword that you will see in questions a lot. Once you see it, you know, okay, there is a problem with norepinephrine and epinephrine. The receptors. The adrenergic receptors, and as you can see, it's alpha 1, alpha 2, beta 1, beta 2, beta 3. Each one of them is found in certain tissue and it exerts some effects. I don't know if they will ask us about each of them, but try to have a general idea. Okay. Here the vasoconstriction for alpha 1. Increase heart rate and contractility for beta 1, and for beta 2 vasodilation and bronchodilation. These are the main things that you will see, but hopefully they will not ask much about it. This is also the same thing. You can see here, this is the efficiency of catecholamines for adrenergic receptors. Not all adrenergic receptors love the same thing, okay? So for alpha 1, they love more norepinephrine. Alpha 2 love epinephrine more. Beta 1 doesn't matter. Beta 2, and it loves epinephrine much more than norepinephrine. You will not be asked about this, most likely. Now the effects, they are the emergency hormones. So they are also countering insulin, glycogenolysis and gluconeogenesis, increasing lipolysis. And you want to have the energy, so you will start breaking down everything. And as I said, they counter insulin, so they're inhibited. The general function, they, as we said, increase cardiac output, blood pressure, oxygen consumption. Think of emergency, fight or flight reaction. Pheochromocytoma is a tumor of the medulla, of the adrenal gland. Okay, it's it can be in the medulla, okay, or it can be outside, but mostly 90% of it will be in the adrenal medulla. The other 10% might be in the sympathetic ganglia, in the abdominal wall, or in the thoracic part of the body, but it's mostly the adrenal medulla, okay? And it will secrete excessive amounts of epinephrine and norepinephrine. As you can see, there's this rule of 10%, that it's 10% malignant, 10% bilateral, blah, blah, blah. Not going to be asked, but please remember, these symptoms, they will have sudden high blood pressure, episodic, it's mostly episodic. They will have palpitations, tachycardia, pallor. All of these are things that have to do with sympathetic, with the sympathetic activity. But then, two things to keep in mind here, and please keep them in mind. When they have high norepinephrine and epinephrine, so they will have high VMA, which is the degraded form, right? As we said. If you have high VMA, it will present in urine. Now you know this is mostly pheochromocytoma. So when you see in a question that's asking about high VMA, know that it's pheochromocytoma. Okay? Okay. Another thing that you want to keep in mind, how do we reverse it? You will give it antagonists of the adrenergic receptors. You have alpha and beta, so you will give alpha antagonists and beta antagonists. But which one first? Always A before B. A before B. Please keep it in mind. Why? If you block the B receptors first, which one did we say have the vasoconstriction activity? The alpha. So no beta. You will have only alpha. If you have only alpha, all of these, of this high epinephrine and norepinephrine will go and bind to these receptors. And they will cause a very, very, very strong vasoconstriction that might lead to the patient dying. So you want to always inhibit A before B. Questions? It's A. Because as you can see, low dose and high dose, they both failed. So this is not coming from a normal place. It's bronchial epithelium or small cell lung carcinoma. The answer is B, because this person has Addison disease, so they have low aldosterone, so you reverse what aldosterone does. So they will have acidosis because aldosterone usually have alkalosis. Now, the answer is B, because as you can see, they have ambiguous genitalia. This means right away that they have low sex hormones. Which one has low sex hormones? It's only I messed up. Okay, let's relook at the question. Okay, this person has let's start by this. Hyponatremia, so low sodium, so low aldosterone. Hyperkalemia, okay, same thing. And hypotension. The only one that had this was 21B because you block it above DOC. The others have high aldosterone. Because this is a female, okay, apparently, the ambiguous genitalia one, because it says enlarged clitoris. So she actually has high sex hormones. For the endocrine pancreas, the histology is very simple. You have these pale, whitish islands or islets of Langerhans. And you can see them easily in a histology slide. Once you see it, it's basically islets of Langerhans, and these are the endocrine parts. They have three main types of cells. Alpha cells, which secrete glucagon, and they are 20%. they are more in the periphery rather than the center. Beta cells, 70%, they secrete insulin and they are more in the center rather than the periphery. You can't really differentiate between them, even though the doctor pointed here that this is an alpha cell and this is a beta cell. But after searching a lot, apparently you cannot, except in special stains, okay, that we will discuss in a minute. Delta cells are 10% and they secrete somatostatin. Okay. As you can see, alpha cells in the periphery and beta cells in the middle. This special stain is called Mallory-Azan stain, and it gives 3 colors. Alpha appears reddish, beta will appear brownish orange, as you can see this one, and delta cells will appear a bit bluish. If you look at the cytoplasm here, it kinda is bluish compared to the others. And this is a summary of what I just said. These are some other types of cells that Dr. Yaqeen said it's not very important to know. So P cells, secrete pancreatic polypeptide, and so on. Not very important, these types of cells, okay? Insulinoma is a tumor that secretes a lot of insulin from beta cells. And it will show, of course, low glucose because it will go to the cells because of insulin, high insulin, of course, and high C-peptides. And we will discuss what C-peptide is in a minute, and then it will make sense. Okay, now let's see how do we regulate all of these cells. Insulin regulation. Beta cells will be stimulated by any type of food, so glucose, amino acids, and fatty acids, but to a lesser extent, so it's not written here or in the lecture. You have the GIT hormones that we discussed before in GIT, like gastrin, and also incretins such as GIP, which is the long name, if you remember, glucose-dependent insulinotropic peptide. It will stimulate insulin. Parasympathetic activity, because in parasympathetic activity, it's more like rest and digest, so vagus stimulation. You are resting and digesting, so insulin is the perfect hormone for post-eating, after eating, which we call postprandial phase. Alpha cells too, so glucagon, and that's a bit, at first it does not make a lot of sense because you think of them as if they were against each other, but actually beta cells can be stimulated by glucagon because you don't want to raise the blood sugar a lot. You want insulin to regulate it. Okay, so when you release glucagon, you will have some insulin that will help with the regulation. It will be inhibited by sympathetic nervous system, fight or flight, no time for insulin to, we want the glucose in the blood to use, okay? We don't want to shift it into the cells. And then delta cells, which basically somatostatin, they inhibit everything. As you know, somatostatin inhibits everything. Alpha cells are the opposite. Sympathetic nervous system will activate it, fat. I want you to, CCK here, and hence it's fat. But I want you to remember something here. Amino acids. Why do we have amino acids? Why do they simulate glucagon? They simulate insulin, and that makes sense because food, okay? Why do we have it? Why do we have it simulating glucagon? Well, the answer is amino acids do not raise the blood glucose much, okay? But that stimulates insulin. So insulin will come and it will shift the glucose too much into the cells, even though you did not raise the blood glucose that much, aslan. So what's the problem now? You will have hypoglycemia. Glucagon will be secreted to balance it out, okay? So you don't have an extreme effect of insulin. It will be inhibited by glucose. Delta cells also will inhibit, as we say, everything. And alpha cells. So even though beta cells will simulate, alpha cells will, this is a mistake here. It should be beta cells, okay? Beta cells, even though glucagon activates beta cells will come and inhibit it, okay? Somatostatin is only stimulated, it's not inhibited by anything, as you know, and that's by glucose, amino acids, fat, all kind of food, and alpha cells also, and GIT hormones. This is a summary. Now for the structure, what is insulin? First, it's pre-pro-insulin. It will be cleaved, so you cut the pre and you get the pro-insulin. Okay, this is how I like to remember it. What is pro-insulin? It's the insulin that we use, which is A plus B insulin chains, it's 2 chains, okay? And a connecting peptide that connects them both. We call it C-peptide. After C-peptide cleavage, so once we cut the C-peptide, you will get the insulin. So pro-insulin will become insulin. and it's stored in granules with the C-peptide. So it will be released later with the C-peptide. Here's the part that is very important. Each time 1 unit of insulin is secreted from the beta cells, 1 unit of C-peptide is also secreted. Because for each one of those, you have one of those, right? C-peptide this makes the C-peptide a great indicator of endogenous insulin, which means the insulin that we produce in the body. Why? Because it has a longer half-life and it's more stable than insulin, so we can measure it well. And it tells us exactly how much insulin do you have, because for each one insulin, you have one C-peptide. So if you have 10 C-peptides, it's 10 insulins, and so on. So let's look at the condition and what happens with C-peptide and insulin. Insulinoma, you will have increased both. Why? Because you will have a lot of insulin being secreted from the body, so you'll have a lot of C-peptide. What if you take it from outside? Insulin will be increased, but C-peptide will not. It will be actually decreased. Why? Because you took it from outside. You did not make the insulin in your body. Diabetes mellitus type 1, it will be decreased both because you have loss of beta cells, so no insulin at all, or very low. What about type 2? You have insulin resistance, so you will have insulin, and it can be even increased, and you have the same with the C-peptide, okay? Since you have insulin, unlike type 1. What about chronic kidney disease? Insulin will be normal because it does not have to do anything with the kidneys, but the C-peptide will be increased because you will not excrete it well from the body, okay? Because the kidney is diseased. Sulfonylurea use, we will discuss what sulfonylurea is, but basically it increases insulin, endogenous insulin secretion, and if it does that, of course it will increase C-peptide. But just keep it in mind for now, and we'll come back to what sulfonylurea is. Now, beta cells, how to secrete insulin from it? They have GLUT2 transporters that are insulin independent, so they themselves do not need insulin, okay? Only GLUT4 transporters are insulin independent. Now, once the blood glucose increases, it enters the beta cells. Let's look at it here. So glucose came into the cell. When you have glucose, you'll have glycolysis and all of that, and oxidative phosphorylation. The final product will be ATP, right? High ATP in the cell because of high glucose, okay, will close these channels, which we call ATP sensitive potassium channels. So the main job of these channels is to secrete potassium outside, secrete potassium outside. Now you blocked it with ATP. So what will happen? Potassium is accumulating here. It will cause depolarization of the cell. And once you depolarize, you have depolarization, calcium will enter by voltage-gated calcium channels. You have high calcium inside the cell, then insulin granules will be secreted. Sorry, I don't know why I'm saying secreted. Anyways, so does that make sense? I hope it does. Now, sulfonylurea, this drug that we explained, that we talked about in a minute, it blocks these channels without the need of high ATP. So it does the same job as the ATP. So once it blocks these channels, it will lead to insulin secretion because of the potassium here, and then the calcium and so on. So it's basically, it does the same job. This is why in here we had increased insulin and increased C-peptide. Now for the receptors. We secreted insulin. How does insulin affect the cells then? The receptors of insulin are found in the skeletal and cardiac muscles and the adipose tissue. It says here and the liver, but it's not the main location, okay? More it was the skeletal muscles and adipose tissue. Okay, this insulin receptor is a plasma membrane tyrosine kinase, which is made of 2 chains, alpha and beta. And once insulin binds to it, it will activate and phosphorylate a lot of things and all of that. You don't need to remember much because this is more of a mole objective. I just want you to know that the pathway that it uses is tyrosine kinase receptors, and it activates this enzyme, which is IRS or IRS pathway. Just remember, IRS pathway. What is the effect? GLUT4 transporters will, in these cells that we just talked about, they will come to the cell membrane, yes. And once it goes to the cell membrane, glucose can enter the cells, okay? It will also increase the entry of other things such as amino acids and potassium and phosphate and magnesium. We'll talk more about it later. So, the effect of insulin, please, this is the most important sentence. If you remember this, you will be able to interpret 99% of insulin effects. It shifts glucose and other building blocks, the small molecules that we will build from. It shifts all of that into the cells to promote its use and storage. So it has a general anabolic effect, so it builds stuff. It always wants to store the fuel that you have. So what will happen? You have glucose, let's take it to the cell and make a bigger thing, which is glycogen. You have fatty acids, let's take it into the cells and make bigger blocks, which is triglycerides. You have amino acids, let's take them into the cells and make bigger stuff, which are proteins. This is like a summary to everything. Also here, it will also take glucose and makes this alpha glycophosphate for fats, because this is the building block that we will use for triglyceride synthesis, because it's 2 fatty acids with one of these. Okay, so as I said, you take building blocks and you make bigger stuff. This is basically what insulin does. So where does the insulin affect? It's mostly, as we said, in skeletal muscle, cardiac muscle, and adipose tissue. So these are all not affected by insulin, okay? Now, for the proteins, as we said, we'll take the amino acids, we'll make them, protein. But why don't we take amino acids into the liver? It inhibits that. Because the liver does not take it to make proteins. The liver is a bit sneaky. It takes it, and by these enzymes of the liver, it turns amino acids into glucose. We don't want that. We already have enough glucose, right? So, you don't want that, so it will inhibit that. And it will inhibit, of course, protein breaking down. Of course, it will promote lipogenesis. This is not how you write it, by the way. It's English is my second language, as you can tell. Now, storage of lipids and lipid droplets and very low density lipoproteins or very low density lipids or whatever. So basically, it will store the lipids. Okay. Now, two things here that I want to keep in mind. We have these 2 enzymes: lipoprotein lipase and hormone sensitive lipase. Lipoprotein lipase is the one responsible for shifting lipids into the cells. Does this match what insulin wants to do? Yes, it does. So it will be activated. What about hormone sensitive lipase? It's always the opposite. So what does it do? It uses the fat. Okay, so it takes the fat and breaks it down to use it. And this is not what insulin wants to do, right? It wants to store rather than use. So what will it do? It will inhibit it. And of course, it will inhibit fat oxidation, because as we said, we don't want to use the fuel. We store it. We rather store it. Now, insulin effect on ketones. It's anti-ketogenic. Okay? Because to make ketones, ketone bodies are something that we can use other than glucose. But we already have high glucose, right? So we don't want to have something instead of glucose. That's not what insulin wants, right? Because when insulin is here, this means that the person just ate, for example. Okay? So this is not what insulin wants to do. So it will inhibit ketone bodies formation. We don't want them because we already have glucose. Now, the effect of insulin on hepatocytes and so on, I will not dig deep into this because this is more like mole, unfortunately. You already know the effects, the general effects, okay? So basically, it will make glycogen synthesis. The enzymes, unfortunately, I'm not sure if you need to memorize them or not, but they are mole. If you just read them for a bit, I think it will be, inshallah, easy. But as we said, glycogen synthesis and glycolysis, okay, will be activated here. And it promotes synthesis and storage of fats by increasing the activity of acetyl-CoA fatty acid synthase. So you will make triglycerides, and it will promote protein synthesis. In the muscles, it's similar, but you don't have the fats effect because you don't have fat here. So it will be mainly about the glucose and so on. And of course, please remember that in the liver, you have glucokinase, which is regulated, and here you have hexokinase. Okay. Promotes protein synthesis and inhibits protein breakdown. We know that. What else? Yeah. And the adipocytes, as we said, the main things that we have discussed already is that you will have alpha glycerol phosphate happening from coming from glucose because you want to build triglycerides, and this is very important for triglyceride formation. You will have inhibiting of hormone sensitive lipase because it mobilizes fat and breaks it down. You don't want that. And you will have synthesis of lipoprotein lipase. Okay? Because it shifts uh, fatty acids towards the cells to make triglycerides. This is a summary for everything that we have said. And let's take a look at other effects of insulin, such as its growth effect. It works with growth hormone to promote growth due to a lot of things. It's an anabolic effects and increased availability of energy and so on. So insulin deficiency in fetus, if a baby has insulin deficiency, it will be born with low birth weight. What if the baby has a high insulin, hyperinsulinemia, high birth weight then, and it's called macrosomy. Other effects of insulin, please, this slide is very important, okay? Electrolyte balance, okay? So it promotes the shifting of these electrolytes into the cells. So even electrolytes are not safe from insulin. It wants to shift everything towards the cells. And you will have increased reabsorption of sodium, okay? Please also remember this. It also increases blood pH due to its fat metabolism effects, because ketone bodies are acidic, okay? And insulin inhibits them, inhibits their synthesis. So if you don't have acidity, it will instead be what? Basic. So increased blood pH. It also has a bit of vasodilatory effects. And it decreases the appetite and food intake by the release of neuropeptide Y. And this makes sense because when you have insulin, this means you just ate, so you don't want the appetite to be high, right? Then you will be eating without ending. Now, glucagon. Glucagon is a bit easier because there's nothing much about it here. Just know that it has structural similarity to secretin and GIP, not very important. It's synthesized like insulin as pre-proglucagon, then 2-proglucagon, and then glucagon. What's its cellular action? The liver is the main thing. Please remember, it's different than insulin because it affects the liver mainly. The receptors are G protein-coupled receptors that use CAM pathway, if you remember, and CAM second messenger system, as we just said. Okay, so what's its effect? This sentence summarizes everything you need to know. It does the opposite of insulin in general. Catabolic wants to break down everything, and it's considered the hormone of starvation. So you will have gluconeogenesis, making glucose. You will have glycogenolysis, breaking down the glycogen that you already have. Glycolysis and glycogenogenesis will be inhibited. Now, this hyperglycemic effect of glucagon does not involve the inhibition of peripheral utilization of glucose. So even though you will decrease the glycolysis and so on in the liver mainly, the peripheral tissue will not be much affected by that because glucagon now broke down glycogen and gave us glucose, right? What is the importance of that if the peripheral tissue will stop using glucose? Right? It will not be able to mobilize this glucose, so we did nothing. So its effect is mainly on the liver, and then it allows the peripheral tissue to use the glucose that we just made. Now, glucagon effect on proteins. Of course, it will, as we said, it wants to break down everything. So we'll have proteolysis, production and transport of glucogenic amino acids. This uptake of glucogenic amino acids by the liver. Do you remember when insulin inhibited that because the liver will take it and turns it into glucose? Now, glucagon does the opposite, okay? So it will allow the liver to take it to make glucose out of it by the most important enzyme is ALT, okay? Alanine transferase, and inhibits protein synthesis. What's the effect on lipids? Also the opposite to insulin, breaks down lipids and makes ketone bodies and fat oxidation. This is just a summary to what it does with some enzymes. By the way, this is not correct by the doctor. It actually inhibits or decreases malonyl-CoA. So please write it down because I think this is a mistake. The doctor, as you can see, once you look at this slide, you will see directly that this means that it inhibits this step, so we'll have less of that. Okay. Why? Because you don't want to make a lot of fatty acids, because then these fatty acids, if you make a lot of them, it will continue to make triglycerides, and that's not an effect of glucagon, it's the effect of insulin. But our fatty acids that we will use and do the fatty oxidation and so on, they mostly come from diet. Okay, summary to everything that we just said. Okay. Now, glucagonoma, tumor of secreting glucagon. How does this patient, okay, I will not dig deep into any the case itself, because it's self-explanatory. And you will have high fasting glucose, high glucagon, high glycated hemoglobin, and so on, but with relative normal insulin. Now, how does this hypersecretion of glucagon alter hepatic metabolism? Well, of course, it will, the effects of glucagon will be very extreme. All the effects that we have talked about. How do these changes contribute to the patient's weight loss and hyperglycemia? Glucagon increases blood sugar, as we know, and the weight loss because it breaks down the muscles and fats and so on. In this patient, fasting glucose is markedly elevated. How is the normal counter-regulatory balance between insulin and glucagon disrupted? You have normal insulin, high glucagon, so glucagon will destroy the insulin, and it will the effect will be so extreme that insulin effect is not important anymore. Now, necrolytic migratory arrhythmia is partly driven by amino acid deficiency. So here it's asking, why do we have low amino acids in glucagonoma? Okay. Basically because, as we said, glucagon will take the amino acids to the liver and make glucose out of them. So you have just destroyed your amino acids. And how does insulin repair that? Because it does the opposite. How does glucagonoma induce hyperglycemia differ from hyperglycemia in type 2 diabetes? Here the problem is from the glucagon, and in type 2 diabetes it's from the insulin resistance, as we will discuss inshallah in the other lecture. Now, the second lecture, we will be talking about diabetes in this lecture. So, why do we control the glucose levels? Because high glucose levels in blood will be a disaster, okay? Because it will cause high osmotic pressure and it will drag water towards it and so on. We will see the problems that we will have in a minute, inshallah, in diabetes, okay? Okay. Now, hormones and the relation to diabetes. I just want you to remember that all hormones counter insulin, whether it was growth hormone, cortisol, or glucagon, whatever, except for thyroid hormone. They kinda have some mercy on insulin, let's say, and they help insulin by increasing glucose uptake by tissue. But nothing other than that will be changed, okay? All hormones, whether it was a growth hormone, cortisol, glucagon, or epinephrine, or whatever, they counter insulin effects. And at the start of someone having, for example, a starvation state, the first hormone to act will be epinephrine and norepinephrine because they are the hormones of acute stress. After a while, cortisol and growth hormone and glucagon will start exerting their effect. Now, diabetes. What's diabetes? It's a complex of polygenic metabolic disorders. How do we define them? By hyperglycemia, high blood sugar. And it's mainly this: higher blood sugar than 126 milligrams per deciliter. Anything more than that, it's, of course, fasting blood sugar. Anything more than that is considered diabetes. In type 1, it's insulin dependent, and it's destruction of beta cells. The beta cells are cooked, okay? Now, in type 2, you will have high insulin. Why? Because it's not the beta cells that are destroyed. You have insulin, but the cells are not responding to the insulin. So you will have insulin resistance. Okay? Okay. Type 1 usually appears at any age and in young ages mostly, while type 2 will be gradually, and it does not come in a day, and it's mostly in people who are older because it takes time to happen. People who come with type 2 diabetes will be often overweight, while type 1 diabetes will be often lean because they have low insulin, so they will not be, they will have muscle wasting and so on. Okay, now I want you here to look at also the ketoacidosis risk. Insulin inhibits ketone bodies formation, if you remember. In type 1, you have low insulin, right? So you will have high probability or possibility of getting ketoacidosis. While in type 2, you will have normal insulin or even high, and then you will have low chance of getting that. How do we treat them? For type 1, it's mainly lifelong insulin therapy because they don't have insulin at all. There's nothing you can do. But for type 2, lifestyle changes are the best thing that they can do because it helps a lot. And if it's very bad, they can also take insulin or oral hypoglycemic agents. Now, how do you diagnose diabetes mellitus based on physiology? Okay, let's look at this curve. Okay, this is a normal person, and their fasting blood glucose is almost 90. This is the first difference that you will notice, is that someone with diabetes will have their fasting blood glucose very high, almost 130. Okay. The other difference, you tell this patient and this person and this patient to take glucose. Look what happens. This normal person will have this rise, and then it goes down right away within 2 hours. Now the other person, the raise in blood sugar will be very extreme, and it will take ages before it goes down, maybe 6 hours or something. Okay, so these are the main 3 differences that you will see. Now, the response to hyperglycemia. How does the body respond in normal people, type 1 diabetes and type 2 diabetes? We say that the response is in 2 phases. The first phase will be the immediate response. Once the blood glucose is high suddenly, the beta cells will have their extreme response by increasing insulin so much, as you can see. Then there will be a drop, and then it will start having this second phase, which we call the gradual phase, okay? Or the gradual release, which is the beta cells now know that there is glucose, and they will start producing little by little for a long period of time. Now let's look at this in type 1 diabetes. Nothing at all, because there is no beta cells aslan. Okay? What about type 2 diabetes? The first phase will be gone, because the beta cells, the sensors are gone, because they always have high blood glucose. Okay, so it does not know anymore what to do. But the second phase will be just abnormal. It's there, but a bit weird, as you can see. So as you can see, this is a summary. Now let's look at type 1 diabetes mellitus in this person. This person basically has type 1 diabetes mellitus, and she has bulimia. So this is an eating disorder where she suddenly felt like she wants to eat a lot. And she probably was depressed or something, so she skipped her insulin injections. So what will that lead to? She ate a lot, she has type 1 diabetes, so no insulin, and she skipped her shots. A very high fasting glucose, and also glycated hemoglobin, because the normal, by the way, is you diagnose diabetes mellitus from 7% almost. So this is very high. So what type of diabetes mellitus does she have? 1, what pattern of insulin secretion? Disappeared or absent. There is no insulin secretion here. Why does she experience weakness? There is muscle wasting because of low insulin. How can skipping insulin injections help to decrease weight? As we said, muscle wasting and fat breakdown. Why should patients with chronic disease be evaluated for depression? Because people who have depression, they will not listen to the doctors, and they will not commit to their medications and so on. Now, what's the effect on carbohydrates when we talk about diabetes? It's very self-explanatory. You don't have insulin, just reverse everything. The final thing that we will reach is that we have hyperglycemia. This hyperglycemia will lead to two main things, okay? Or 2 main symptoms that you will see in patients. The first one will be that the hyperglycemia will pull water from the cells, causing cellular dehydration. Okay. Now, the other main thing, that the glucose will start appearing in urine. And if it appears in urine, it will drag water towards it, so you will have a lot of water in urine. So these patients will have these 2 main symptoms that we also always talk about, which is they want to go to the bathroom a lot because glucose will pull water towards it in the kidneys, and they have dehydration because they are losing a lot of water, and they have cellular dehydration, so you will have excessive thirst. They always want to drink water, which is polydipsia. Now, what about protein metabolism? As we said, we'll reverse everything, so we'll be breaking down a lot of proteins, leading to weakness and so on. And this is also important. We will have high excretion of urea, because urea is one of the products of protein metabolism. Okay, this causes what we call negative nitrogen balance, because we are excreting a lot of nitrogen, more than what we are making. This is a sign that we have protein metabolism problem. We are breaking down our protein and we have muscle wasting. Effects on lipid metabolism. As always, reverse everything that we know about insulin, and it will eventually lead to this ketoacidosis and ketonuria and so on. Basically, ketone bodies will be a lot, fat oxidation is high, which is opposite to what insulin does, and hence they will might have DKA, if you remember, guys, which is diabetes ketoacidosis. Now, if a patient with diabetes take a lot of insulin or take the shot and forgets to eat, they might have hypoglycemic coma because insulin will exert its effect, but then there is no recovery. Either it's very extreme because they took too much insulin or they did not eat aslan, so they took the insulin for nothing, basically. And that will lead to hypoglycemic coma if the blood sugar goes too low. Now, what's the effect of hormones? How will they counteract insulin? You know, you have increased glucagon, you have activation of sympathetic adrenal systems, you will have high epinephrine and norepinephrine, you will have the late response, which is by cortisol and growth hormone, because they take time to exert their effect, so their effect will be a bit later. And the therapy will be intravenous injection of glucose. Now for the metabolic syndrome. The metabolic syndrome is basically simultaneous risk factors that come together, and they make a very high risk factor of getting cardiovascular disease or type 2 diabetes. This is defined by any three of these five. These five criteria, please remember them. If someone, first of all, why do we have metabolic syndrome? It's mainly insulin resistance. So it's more related to type 2 diabetes, and it has also to do with the central obesity and sedentary lifestyle. So people who do not exercise, their diet is bad, and so on. So abdominal obesity is the first criteria. Waist size greater than 35 for women or 40 inches for men. Arterial hypertension, more than 130/80. Low high density lipoproteins or high density lipids, which is the good fats. So if you have low of them, this is bad. Less than 40 for men and less than 50 for women. High triglyceride levels of more than 150, this is bad fat. So if you have high of them, this is bad. Fasting glucose greater than 100 or pre-existing type 2 diabetes mellitus will also be one of the criteria. As we said, lack of exercise and poor diet, genetic predisposition leads to insulin resistance, and it will show us these problems that we just said. And one of these problems also will be hyperuricemia, because you will break down a lot of proteins, as we said, so you will start excreting uric acid, and you will also have a lot of uric acid in the blood. Uric acid, I think. Now, insulin resistance. Insulin resistance will lead, as we said, to the opposite effects of insulin. But there is a tiny detail that I want you to note here. All effects are reversed, but except for these. Okay? What's the shared thing here? They all have to do with the fats, okay? Now all of insulin effects are reversed, right? But except for the fat effects, the insulin effects are what is happening. So you'll have lipogenesis and lipolysis, a decreased lipolysis, and high triglycerides, which is the effect of insulin. So why? This is because insulin resistance is not global. There is selective insulin resistance. So not all pathways of insulin will be resisted by the cells. The effects of insulin on fat synthesis, okay, they will not be resisted. It will continue normally. So you will have the opposite of insulin effects everywhere, except when it has to do with fat, you will have high fat. So this is why they present with central obesity and so on. So as you can see, people with insulin resistance, they get the bad of both. So they will have, they will break down their muscles, they will have high fat and so on. This is the metabolic syndrome. And by the way, this is a very important sign of the metabolic syndrome that's called acanthosis nigricans, which is these black spots that you can see on the neck. Now, how many internationally recognized metabolic syndrome criteria does this patient have? He had all of them, by the way. I'll just skip this. What in his history suggests high risk of cardiovascular complications. He smokes and so on. And his father, I think, died by heart attack. How does nicotine increase the risks of cardiovascular complications? It's a vasoconstrictor, and it increases, it activates the sympathetic nervous system, so it makes, it puts a lot of weight on the heart and vessels, and it also destroys the endothelial cells of the vessels. Why can't he control his appetite? He does not have neuropeptide Y, which insulin helped us with, if you remember, which decreases the appetite. Why does acanthosis nigricans develop? It has to do with keratinocytes and so on. Insulin will activate them indirectly. But yeah, not important. What lifestyle modifications does he need to make? Stop smoking, start exercising, and so on. Questions? Stop if you want to solve it, of course. The answer is D. You will have an exercise, you will have glucagon, so you will decrease the glucose uptake, and after a meal you will have insulin, so you will increase. In muscles, both increase. Why? Because glucagon does not affect the muscles, if you remember, it affects the liver. And during exercise, you don't want the muscle to decrease its glucose uptake. It's the opposite, you want it to increase, because we are exercising, so you're using your muscles, so it needs glucose. Hormone-sensitive lipase, glucagon activates it, and insulin deactivated. As we said, it's the opposite of insulin always. Okay, the answer is D. If someone takes insulin, they will have high insulin, low blood glucose, and low C-peptide because it's exogenous. And this is the only one that's this way. So if you want to solve it, the answer is A, because there's a lot of signs that this is type 1. And how do you treat it? Insulin injections. Okay. That's E, because she has ketoacidosis. High ketoacidosis and ketone bodies means they have low bicarbonate, which is a base. One last thing before we finish is this slide. If you guys remember, we have talked about it and we said we'll come back to it. So I'm here to fulfill my promise to you. And basically, we have talked now about the hormones and you know them. So let's take a look. First of all, the first rule that I want to set it up with you is that all hypothalamic hormones in general will be by IP3 mechanism. So these guys will be IP3 mechanism. Also ADH and oxytocin, because they are released from the hypothalamus, if you remember. But ADH, only V1 receptor, which is the vasoconstrictor one, not the V2. We have discussed these in details in the pituitary lecture. Okay, what are the exceptions for this rule? CRH. And of course ADH, V2 receptor. They are CAB mechanism, even though they are from the hypothalamus. Okay, what about the pituitary gland? These guys and this one and this guy, they come from the anterior pituitary and they are all CAB mechanism. Okay, does this make it easier? I hope it does. These guys we have discussed, all of them, steroids, so of course steroid hormone mechanism, and thyroid hormone does the same because it has nuclear receptor. Now the activation of tyrosine kinase, it's insulin, and insulin-like growth factor, of course it will be like insulin, and growth hormone and prolactin. Okay, which are the exceptions for the CAB mechanism of anterior pituitary gland. Now, what else? The rest, you can interpret also glucagon I've talked about and so on. I hope this made it easier for you to remember. It's just tiny things that we did not cover here. So try to remember them because Dr. Abdelrahman emphasized a lot on it. So I am sure, inshallah, we'll get a question or two from these. Thank you so much for your time and for staying here until we finished. I hope this was helpful. This is my email, my phone number. Please feel free to reach out to me if you have any questions or anything you liked, anything you did not like. I really appreciate your support, guys. And thank you so much. See you, inshallah, and good luck.